Hello, how are you, Pankaj?
Hello.
How are you?
Fine, sir.
Great. From India to Brazil. That's
Uh,
amazing. Huh?
Sir, this is a comfortable time for me, sir.
Oh,
Very comfortable
we're
time.
gonna make it like this. I didn't
Yes, sir.
figure out that it's
Yes,
also
yes, yes, sir. In previous webinar, the time is very altered, sir. And that time in India, it was 1:30 a.m., sir.
yes. Pankaj, do you have a earphone? Otherwise, I'm getting my audio again from you. You see?
Sir, sorry, sir. This time I have no earphone, sir.
You don't have?
No, no, sir. Because after OPD, I have just joined this webinar, sir.
No. I know what's happening. It's the YouTube. I have both open. Forgive me. It's
Okay.
my fault. Okay, now it's fine.
Yes, yes,
Now
sir.
it's great. Oh, it was the reverberation because I was with the YouTube. We are live at the
Yes.
YouTube right now, you know? That was
Okay,
not
okay,
your
sir.
fault. It was my fault.
Yes, yes, sir. Thank you very much, sir, for your cooperation, sir. Now
No,
my
it's
page is
great.
becoming, yes, sir. Now my page is becoming more and more connected to all over world, sir.
Yes, but that's an effort. That's a common effort that we have to
Yes,
undertake.
yes,
Yeah,
yes.
it's great
Yes,
because
sir.
I have a lot of connections with people from the US and from the and
And
you have
many people are
connections.
sending so many things on my page. Some are, sometimes it becomes very difficult to just choose that which one I have to post or which I have to just ignore. Sometimes it
Yes,
becomes very difficult for me, sir.
yes, I can imagine because you have the most attendance that we have in the pediatric urology people right now. It's amazing, 4,500 people. That's great.
Uh, yes, sir. It is not the number is important, sir. Rather, it is connected to more than 100 countries, sir.
That's amazing. Well, more than
Yes, sir.
100, more than
More than
100.
100 countries, sir. I will share very soon that how many members are from each country. I will share, sir. Page, sir.
Well, that's terrific. Terrific.
Yes, sir. Yes, sir. And
That's,
through this page, so many pediatrologists are not very known to all members, but through this page, they are becoming more and more famous, sir.
yes, for sure.
And
For sure. Now,
truly speaking, sir, I am living in a very small city.
oh, really? What's the city you live?
It is situated in a very small town that is known as Ramgarh. But through this space, I am connected to world most famous pediatricians. It is not possible to meet personally with those pediatricians, but through this base, I am becoming more and more recent updates.
That's
Familiar with
good.
more and more recent updates, sir. Through this
That's
page, sir.
great. That's great. You know this guy which has just joined us? He's actually Brazilian, but he did his residency in the US. It's Daniel DaJusta, which is a amazing robotic expert. Hi, Daniel.
Yes,
How are
yes, sir.
you?
I'm good. How are you guys? How are you, Dr. Antonio? How are
I'm
you?
good.
Nice to meet you.
Do you know Pankaj from India, Daniel?
Not personally,
Yeah.
just by
Hi,
name
sir.
and here. But it's very nice to meet you.
Yes, yes. Actually, Pankaj started several years. How many years ago, Pankaj?
Approx 3 years, sir.
3
2 to
years
3
ago.
years.
Yes.
Yes, sir. 3 years.
He has a Facebook profile for pediatric urology who has 4,500 people attended from 100 different countries, you know, more than any society in the world.
That's good.
And he was always putting some cases for discussion and asking people to contribute. And at the beginning, I give some contributions and several people too. And then it was growing.
Huge.
It's terrific.
Hey,
Yeah, that's great. That's amazing. That's good. And how are things in Columbus, Daniel? Good?
Everything is pretty quiet. I mean, pretty good. I mean, we're back to doing cases. Everything's going well. Cases numbers are going crazy. You know, the virus numbers are a little bit out of control in the U.S., but in Columbus it's still, and here in Ohio it's still pretty mild. I mean, compared to everywhere else in the other states.
Yeah.
But you know, when you look outside when you compare even Columbus compared to other countries, it's a lot of cases. But I don't know. You just gotta, there's nothing you can do. We gotta keep going. But we just went back to being busy again this month, so it was actually good after a couple months of a lot of nothing.
Yes, you're right. In Brazil, it's the same. We had some trouble, but São Paulo is really quiet right now. It's really very quiet, and this month we came back to work, so it's great. Hi, Mark.
Hey, good morning.
Well, we're connected Seattle to India to Columbus and to Brazil. That's amazing. Oh my God, that's great. Oh, so nice, so nice. How are things in Seattle? You live in Seattle, is that right? Or
I am, but I'm on the Oregon coast right now, down at our beach house.
yeah, so great.
Nice.
That's nice. That's great.
My kids all moved out from Texas to so they could work remotely.
Yes.
So they all moved out to Oregon for about 2 months. So
oh, that's
the
nice.
grandchild and the kids, it's a lot of fun.
But you know that this afternoon I'm moving to Guarujá as well. So the whole family will meet my parents, my brother, my nephew will have a birthday, so we'll make a barbecue tomorrow. So it will be good.
I love it.
Yes.
I love it.
Good.
Oh.
Oh, you know Daniel well, don't you? But Pankaj, I don't think you know. You know Pankaj?
Have we met? Your face looks familiar, Pankaj. Have we met at a meeting, maybe?
Yeah, I don't think so. Did you met Pankaj? Pankaj is holding a very popular Facebook profile with 4,500 people.
That's fantastic.
He's the guy who's making our meetings international through connections in 100 countries. It's amazing. So he always put in some cases for discussion and asking people to give some insights. And then through this, he started to be very popular. So it's amazing. Yeah.
I might have to join Facebook. I don't know.
Yeah. In Brazil, my patients love to be my friends. So my Facebook is not for personal reasons. I always put in something connected to medicine and to music, which is my passion. And through this, I get all my patients very integrated. So it's good. They find it very nice. Yeah.
You're a very good guitar player for sure.
Yes, I like guitar player and also trumpet in the last 4 years. It's really my best hobby to do. It's amazing. Good. Yeah.
So Antonio, how's the virus down there?
Well, in São Paulo, it's really very nice. We still have 1,000 deaths per day, but spread out in the country, which is, I think that you have as well. How many deaths you have per day? And
pretty close, about the same, I think. Yeah.
So, but in the city, the main cities, it's gone. The intensive cares units are empty, and then but if you go to the interior side of Brazil, there are cities that are getting some cases. So it's the natural history of the virus, I believe.
Yeah, I think it's right. It's kind of hopped all over the U.S. for the last 4 months, kind of different little spots, but
yeah. Well, let me check if they are having trouble to connect, because It was
Dan, how are
pretty
things
easy
in
to
Columbus?
join. It wasn't.
Well, down here, it's, Ohio's not too bad. I can't complain, Mark. We're pretty steady, kind of climbing now again, but it's not to the point where we're scary. The hospital it's back to normal routines.
Yeah.
And I don't know. I think it's just my fear is that if we do get a spike or with the flu season lurking, and which will complicate things, you're not going to know if you have flu or if you have the COVID, what people are going to do. I mean, another shutdown seems unlikely.
Yeah.
No matter how crazy the cases go. So I think part of what the government is trying to figure out is like, well, just we'll let things get crazy slowly and nobody's going to notice. Kind of almost feels that way. Which is sad, but
yeah, I like your governor. He seems very level-headed.
He is. I mean, I would wish he would come down harder on the mask thing, which I think everybody thinks is the right thing to do. But he's hoping, which I think is difficult, that everybody would do the right thing.
Right.
I don't know.
Me too.
We all hope that people do the right thing.
And who will win the elections this year? Trump or Biden?
Is this recorded?
Yes, live, brother. let's
comment.
Let's stop. Okay.
I don't know.
Oh my God, it's but the same is happening in Brazil. The polarization, everyone against Bolsonaro is amazing. And if you look what he's doing for the country, it's really good because he's putting some trouble with people that had a lot of advantages. Mm-hmm. So the establishment is against him. But the economy is improving. He gives a lot of support to people, to poor people. So actually, I don't understand why they go so rude with him, because he's doing, in fact, a very good job in the economy.
Well, part of it is he suffers from the same problem that the president here suffers. He has the need to be recognized for doing a good job.
Yes,
and to be in the news. I mean, if both of those presidents just did their job and quietly,
that's what he's doing right now. He's not saying a word. So the journalists, they are crazy because they don't know what to do, because the good news are appearing. The economy is recovering. He gave a lot of support. So if he stays quiet, I think it will be better.
Yeah.
Because he has a board of ministers, very good board of ministers. So let's see. Well, it's a pity that I can't have you here personally. Né? We should be waiting for a caipirinha and barbecue after this conversation. It's a
the best.
Yeah.
There's something different about the caipirinhas south of the equator, Antonio. I tried to make them here on the beach. With my
it doesn't work.
The shaka from Brazil that Sergio had brought me didn't work.
Yeah, that's right. It's terrible.
They thought, what is this?
Yeah.
They're delicious. Really, trust me.
Okay. It's interesting.
Pankaj, where do you live?
Pankaj?
Pankaj, where do you live? Which city?
Sir, your voice is not very clear, sir.
Which city do you live in?
Sir, my city is Ramgarh. It is situated in India, sir.
Oh, very good. Big city?
Small city, sir.
Small in India is big in the United States.
That's why I have created this page, sir, so that I can connect it to famous cardiologists who are doing very extraordinary work. And now through this platform, I can learn all the skills.
Yeah, that's fantastic. How far are you from? How far from Mumbai are you?
It is very far from this city, sir.
Ah, Tony.
More
Tony
than,
was your resident. Yeah, sorry.
Sir,
Okay, Scott, sorry.
how many people are connected, sir?
Well, there were almost 250 registrations, but
250.
now this will be sent to YouTube. So in the Zoom, only us, so that only us can talk and we don't have some interruptions. Hi, Tony.
Hi, how are you?
I'm good. Great to see you.
I think Tony is a very permanent member of this space, sir.
How's everyone
Hello, sir.
doing?
Good.
Good. So we are waiting for Pramod and for Greg, no? And then we are done. Still have 7 minutes. Okay. Everything good, Tony?
Yes, great.
Mm.
I had to round this morning, but came back, no problems.
Oh, good. What about operations? They are coming back?
Yeah, they're coming back. I had a kind of a flashback to fellowship, as I told Mark Cain. I was doing a prune belly patient 2 days ago.
Oh,
and
good.
the patient had a malrotation.
Oh.
So then I remember back in fellowship that we had this, and I said, we're going to call the general surgeons and have it fixed.
You did a Montfort?
Mark knows the other half of it.
What did you do?
You know, I had done orchiopexy because I was going to delay reconstruction. And then, of course, with the orchiopexy and the VAS, a little too much pressure on the ureter. So things started, you know, as Mike Mitchell would say, some of these kids, as the VAS comes up over the ureter, it can, when you do the orchiopexy, it can impede the flow. So I'd already done the orchiopexys, but.
We do it very early on, all together.
Well, I'm going, and that's what Mark had told me. And patient was not from Richmond, so I'd kind of delayed things a little bit. And so
yeah,
the orchiopexys were driving it. And, but it's one of those things that now you see why your mentors do it early.
Can you guys hear me?
Ah, yeah, Greg and Pramod. We have the whole team right now.
I'm
good.
I'm looking though. I can't see myself, which is.
You can't see yourself?
That's a good thing, Greg.
Probably.
That is. I think this system kind of sorts that out, Greg. So if you're not appropriate to be seen, then you can't.
I love
see
it,
yourself.
but I can't see you. I can't see you guys either. I'm going to try logging in again.
We can see you.
Oh, you can.
So Tony, how old do you do the prune belly? 1?
Well, actually, about 1 year, between 9 months and 1 year, because it's pretty an abdominal wall surgery. It looks as a big surgery, but in fact, it's not. And what we did in the past, but after some experience, because the main problem is residual volume. So we were doing at the same time a Mitrofanov when we do the Montfort, because they have residuals and they have sensibility. So it's tough to get catheterization by some patients.
And so at 1 year,
we noticed that half of them, just with the abdominal reconstruction, they don't need any more residual volumes. It's amazing how they improve the abdominal transit and even the bladder function. It's amazing, just by the abdominal wall reconstruction.
And you do tapered reimplants at that age too?
Do what?
Ureteral reimplantation?
No, just bladder wall and eventually a Mitrofanov for some cases. Yeah. When the residual volume is very high, because you are there, you know, there is very few morbidity in putting the appendix at the same time. If you
Right.
come back later, it's a bigger operation. But
This patient had obstructed a little bit from the orchiopexy is what
Oh.
drove me to, because the vas was pinching it
I see.
and the ureter.
I
So
see.
that's why I was asking. The age was more from the tapering. But it's interesting, the more proximal you go, the ureter is less dilated.
Mhm. It's
And if you can get all that dilated ureter out, then you're kind of, I plicated one side. It wasn't even that dilated. But
yeah.
interesting, I think that everyone has their own way and age to do these
For
kids.
sure.
There's wide practice variation.
Yeah, you're
Wide
right.
practice variation.
Pramod, can you hear us?
I can hear you.
Oh, great.
Pramod, there he is.
You
Transferring my
seems
talk,
you are very busy. Still
no,
busy.
transferring my talk from one to the other computer. So is this
Ah.
He's just finishing his talk.
Oh, yes. So let's give Pramod some minutes and then we can start.
Yeah, as was I last night.
Yeah. Where are you, Greg? You are in Philadelphia or in the South Carolina?
I'm in Philadelphia right now. What's happening with it's very hard to get to South Carolina right now. It's
Oh, really?
just with the COVID restrictions. But I'm enjoying myself. I'm not on call today, and it's a beautiful day, and I might get out and play some tennis later on.
Yes. I'm on call today, but to go to the beach to Guarujá.
Nice.
Dude, I'm on call too, so that's part of the reason why I'm busy. I'm just getting one thing ready to go.
Yeah, I was rounding, and one of the texts that said 11, and although you at great length, Tony, told us the times and the city, I was rounding thinking this was at 11, and Greg texted me. So I had to come home from the hospital.
You know, I got your back. Don't worry.
You do.
Okay.
You do.
Well, it's amazing how British we are, aren't we? It's 11 sharp. Greg, I think it's because of you.
Perhaps. You know, right now I'm actually renewing my English passport because of travel restrictions. It's the only passport you can travel with out of the U.S. right now.
Okay. Okay. So I will. We have aquí like I said, let's say, Pramod, you start.
Yes, sir.
Long-term complications of catheterizable channels. I'll talk about our concept here in Brazil. Then Mark Cain will talk about the long-term outcomes for patients with MACEs. Then we can debate a little bit. Everyone can ask questions, can pose questions. Then Tony Herndon will talk about bladder, neck, and slings. Then Greg will talk about the split appendix for Mitrofanoff and MACE. And then Daniel will talk about a robotic program, okay?
Perfect.
So I will press my button here. Now, okay, now I'm recording. So I would like to thank you very much, all my friends, for this opportunity. It's a pleasure for me and for Pankaj, which has helped me in these meetings. I'll let him talk a little bit about his project before we start. But it's a pleasure to put you all experts from the world together to discuss this tough topic. But it's for sure one topic that we like, these complex reconstructions. So it's my pleasure to have all of you. I will give you some minutes for you to make a welcome message, starting with you, Pankaj. Do you like to tell about your project and how you are developing this Facebook profile in pediatric urology? Thank you very much, all of you, okay? Pankaj?
Sir, thank you very much, sir, for your support. And one thing I want to say that those pediatric urologists who are not doing this surgery very frequently, this webinar is very informative. And I think it will be very informative for those pediatric urologists. all the best of luck for all speakers, sir. Thank you, sir.
Okay, Mark, your welcome message, please.
Well, I think it's just really great to have this kind of a forum, Antonio. I give you great regards for putting this together on this notice. It's always good to be together, but this may not happen for a while, and we need to learn how to do this and exchange ideas still and learn from each other. And this is a great format. So congratulations to the team down in Sao Paulo. I wish I could be with you in person, but this is the next step.
This webinar thing is terrible. We want to be there with you and party. And
Yes, it was a pity.
Have some caipirinha.
Yeah.
Yes, for sure, for sure. And
Still a good
actually,
venue, so thank you.
yes, the reason for this meeting is that we have every Friday, our team comes to this AACD hospital, which is an amazing spina bifida hospital, which we have 3,500 neurogenic patients under control. Pankaj has visited us and did a lecture there. Tony and Greg as well already know this hospital. So it was the main reason for this meeting, because they are celebrating 70 years. So it's a good reason for us for this debate. Pramod, can you make some welcome message for all of us, please?
Absolutely. No, thank you very much, Antonio, for having me be part of this esteemed group. I'm looking around on the screen there and see many friends that I haven't seen in a while because the meetings have all been canceled, but it's great to be included in this wonderful group of thought leaders in pediatric urology. And I'm excited to hear all the learnings that we're going to have today. I just want to echo all the sentiments that Antonio, thank you for taking the initiative of putting this together. Pankaj, thank you for your help in all the making all the arrangements. I think it's going to be a really wonderful offering and looking at, challenges that we face as reconstructive pediatric urologists. So, and thank you to my colleagues for, Saturday morning, spending your time being part of this. Mark, you're looking good there, brother.
Okay, so I have two brothers from another mothers here as well, okay, which is Tony Herndon and Greg Dean. So please, you two guys can make a welcome message before I take to Daniel. Tony.
Sure. Well, I would say, I'll let you go, Tony, first. Why don't
Oh,
you-
thanks. Yes, thank you. I was just thinking as everyone's doing their salutations that we're coming up on another year, and I feel like I need to start packing for my trip to São Paulo, because this has become quite a tradition over the last 5 years. And what I'm thinking is that maybe a big event, this all was kind of founded on big events, the U2 concert, the Amazon trip. So maybe Formula One in 2021, we could all visit São Paulo and maybe watch Lewis Hamilton race down there and visit the Ayrton Senna is quite the legend in São Paulo. So those were my thoughts, but I would like to thank you, Tony, for putting this together. I think you do amazing work, you and your team. I would say I think it's underappreciated. And, in the field of reconstructive surgery, you do a lot of work with antenatal intervention that even to this day is I think missed when folks are writing large reviews. And I know that happened recently, and I that's just an example of that. So I think these formats are great. I'm honored to be here with one of my mentors, Mark, and my other friends as well. So thanks for the invitation. I'm looking forward to a great meeting.
Okay.
Tony, Tony and Tony. So we were the three hombres when we were down in Brazil watching U2, and this original last year, our meeting that was born of it occurred, and then this meeting in part is really related to that because we were all supposed to be in Sao Paulo right now, and unfortunately COVID interfered. But I think that this is, again, the spirit continues, and we were to be at the beach later in the summer, but that's going to be delayed for next year. But I'm sure you're going to talk a little bit about the idea of Pampas at the end of this meeting. But again, I hope to see everyone there next year. It is an honor to be here. I've always enjoyed hearing everyone speak, particularly Antonio Macedo, over the years, and I think this is going to be a wonderful morning.
Greg, I just hope that you write something on that easel behind you. I'm looking forward to that. Some
I
sort of
will.
physics.
I will. That's actually for my daughter for her math problems. I take her through.
She helped you with them?
It doesn't add up. That's the only problem.
Yeah.
Oh, great, great. And now it's my pleasure to welcome a Brazilian American surgeon, which it's really a pleasure to have you, Daniel, that from the north of Brazil. If you are from Fortaleza, from Ceará, aren't you?
Yep.
Okay, Greg, Fortaleza is where we are going to go to Jericoacoara next year. So we already want to invite you, everyone. We'll make the first small meeting in Jericoacoara, so Daniel can be our guide there. So we can already start. So please, Daniel.
Yes, it's a pleasure. Thank you very much, Antonio and Pankaj, for inviting me. I mean, it's a privilege to be among so many important figures of pediatric urology, and I hope I can fit in a little bit. But thank you very much. It's sad that we can all be together, certainly for the Caipirinhas later on, if we could be together. But hopefully, like you said, next year, and especially if it's in Fortaleza, you can count me in. I will drive you guys everywhere down there. But let's, thank you very much again. And let's hope that everything's going to be great. This is the best next thing when you can be together, right?
Okay. So let's start working. But for us, work is not hard, it's pleasure, isn't it? So that's something that we like. That's what our motivation, our passion. So Pramod, you can share your screen and you can start with your talk. Thank you very much.
One thing, I just want you to give Serge a big hug for me, Sergio.
Oh, yes, he's certainly watching us.
His barbecue and his caipirinhas. He makes the best caipirinhas, so please tell him.
Yes, for sure.
Was looking forward to being with all of you this weekend.
Yes, great.
All right. It says here, host disabled attendees.
Oh, I'll put some permit here. Let me see. Yes, now you can.
Perfect. Full screen here. So good morning, everyone from around the world. I appreciate this opportunity to be part of this incredible opportunity that Dr. Macedo and Pankaj have put together. I think that one of the benefits of COVID-19 has been this incredible mushrooming of international education collaborations using these online platforms. And I think that bringing people together via this platform, unfortunately, doesn't have the same benefits of an in-person meeting where the socialization and the friendships are formed and developed. And I have many, many wonderful memories of being in Brazil and being Antonio's guest. But I'm very honored that he invited me to be part of this. So thank you. Antonio asked me to speak today about long-term complications of catheterizable channels. I have no disclosures to make. The way I structured today's talk is just talk about the different types of catheterizable channels and the CCC, continent catheterizable channels. What are the indications, short-term complications briefly, and then spend more time on the long-term complications and outcomes of this, how we manage some of these, and then what are the take-home messages. And again, none of this work would be possible if it weren't for the incredible work and foundation laid by many, many, many thought leaders in pediatric urology. And to quote Sir Isaac Newton, if I've seen further than others, it's just by standing upon the shoulders of giants. And some of my colleagues who are a part of this webinar today are, for me, my teachers and mentors, and I've just been incredibly fortunate to have them in my life. So thank you to all of you. There was a paradigm shift in 1980 in pediatric urology when Dr. Mitrofanoff first described his procedure, and it really revolutionized our ability as functional reconstructive surgeons to be able to offer patients the chance to be dry, the chance to have the ability to wear underwear and have that quality of life that we hope for all children, and really revolutionize what we're able to do. And since its development, the Mitrofanoff procedure has been widely used throughout pediatric urinary reconstruction. It allows for safe, intermittent, clean catheterization. And again, the biggest impact has been on improving the quality of life and essentially giving people their independence, their freedom back. Now, there's been a significant evolution of these continent catheterizable conduits since Dr. Mitrofanoff first described his. So his technique was an appendicovesicostomy in 1980. Dr. Yang and Monty came up with a modification for when the appendix was not available, and that's the iliovesicostomy in 1997. Dr. Malone came up with a alternative approach for a catheterizable conduit, not for the urinary tract, as Dr. Mitrofanoff and Yang and Montes had described, but more for the bowel to, again, allow for addressing another significant pathophysiology in these children, which was fecal incontinence. And so that was described with a series in 1990. Dr. Casal, when he was in Indiana, modified the Monty for patients who have a slightly larger abdominal thickness to traverse with the conduit. And in 1990, came up with a double spiral Monty to make a longer catheterizable channel than was previously permitted. One conduit that I came across during my research that we don't really use much, probably because significantly higher complication rates, was something described by Dr. Rackley in 2006, which he called a CVC, a continent vesicocutaneous channel. And here, they make a small opening into the bladder, but then they use a skin-based tube to traverse the distance from the bladder to the umbilicus. And they reported a significant number of complications. And so I don't think most of us have taken that on. Dr. Macedo, one of the organizer of this conference here, has described a very nice technique, a continent catheterizable ileum-based reservoir in 2008, which incorporates the use of a single segment of bowel that allows both for the augmentation and also creation of a conduit. So you can see that many thought leaders have taken the lead of Dr. Mitrofanoff and expanded upon it to address the various limitations of either body habitus or tissues available for this purpose. And here are two of the initial pioneers of this, Dr. Mitrofanoff and then also Dr. Paolo Riccardo Monti. So what are the indications for continent catheterizable channels? You know, patient pathophysiology. So if someone has a native urethra that is just no longer usable, whether it's for urethral atresia, urethral strictures from repeated trauma, some child that we're going to be doing a bladder neck reconstruction or bladder neck closure on, where the native urethra is no longer going to be access into the urinary tract. Those are, real indications. We also have to take into account the patient's ability to catheterize themselves. So a lot of the spina bifida patients, they do have limited manual dexterity, unable to catheterize through the native urethra. They may have difficulty undressing and positioning for cathing. And so giving them an abdominal-based stoma allows them to be independent in their care. There are also some children who just are very averse to putting a catheter into their genitalia. And so if you have a child who's not going to do it, there's no point in expecting that they're going to be able to do it. So a Mitrofanoff is an alternative. And also the inability to use a native urethra for a patient who's very, very sensate and just doesn't tolerate catheterization through a biologically native urethra, giving them an alternative conduit that does have sensation, but different sensation and is more conducive to being catheterized. I was specifically asked to talk about outcomes and complications. And, I think that we all have to just be humble and honest and say that we all encounter complications. The famous saying is that show me a surgeon who doesn't have complications and I'll show you a surgeon who doesn't operate at all. So, we just have to be honest that these are not benign procedures that we do. So what are the complications of a continent catheterizable channel? The early complications that we have are related directly to the surgical procedure used to create this channel. And these are mostly surgical complications, anesthetic issues, infection, need for transfusion, anastomotic leaks, ileus, bowel obstruction, vascular compromise of the conduit, especially if you're going to be using a split appendix technique. And there you might have resorption of the distal aspect of the conduit. And also leakage can happen very early on. And all of those, have to be managed while the patient is usually still in the hospital. And keep in mind that a lot of times the patients that we are doing these types of procedures on are not entirely healthy. And I would advocate that, really have to optimize their health preoperatively, getting them to do some pulmonary exercises to build them some pulmonary reserve, and also surgical nutrition is a big factor. And we're seeing that by improving their nutrition before we undertake some of these procedures that place a significant metabolic demand on them with healing, do improve the outcomes. Now, looking at the longer term complications, There are a number of complications that can occur in the long term with these continent catheterizable channels. The most commonly being stenosis, stomal stenosis, and leakage, but there's difficulty catheterizing. And we see this as these children grow and become adults and their body habitus changes. What used to be a very straight pathway now becomes a very tortuous pathway. And this can result in false passage formation, stricture formation with loss of access, perforation of the conduit, polypoid formation, especially with the Montes where you have small bowel. They seem to be a little bit less tolerant than the appendix in terms of being able to tolerate long-term access with catheters. Kinking of the continent catheterizable channels, again, as the patient ages and their body habitus changes, you might see that something that used to be so beautiful and easy to catheterize is now all of a sudden impossible to catheterize. Bladder stone's not a direct complication of the conduit, but it is a complication that occurs in the bladder due to oftentimes incomplete emptying of the bladder when you are cathering from a abdominal stoma as opposed to urethral catheterization. Something that has not been written up clearly, but we've seen a few cases of this is fistulas or sinus formations, usually just beneath the skin level from either a microperforation or a subclinical infection. And then these patients present with recurrent abdominal wall abscesses that are often a close proximity to the stoma, but not right attached to the stoma. And sometimes you can endoscopically visualize where the pus is coming from. But oftentimes you just have to go in surgically and just break off all those sinus or fistula connections. And then again, long-term problems from having done the surgical procedure to create the channel can be internal herniations and bowel obstructions due to adhesions. So it's a fairly long list of complications that can occur. And again, brings to our attention that these are not benign procedures that we put these patients through. Just looking through the literature, you can see that there's multiple series here that I presented chronologically that talk about the number of patients with long-term follow-up. Most of these patients have had at least 6 years or 10 years of follow-up. And we can see that the complication rate ranges from the low 20% to all the way up to 60%. So significant rate of complications. Thankfully, most of the complications seem to be stomal stenosis, which can be readily managed as an outpatient. Now, one of the things that we've written up here is use of Kenalog injection to manage stomal stenosis. It's a office-based procedure, avoids the need for taking these patients to the operating room. And one of the keys that I learned from my brother who's a plastic surgeon is that if you just inject Kenalog into a scar, you're really not going to manage to soften it up. What you have to do is you have to really Swiss cheese the scar tissue. So I take a large bore needle and in 3 different planes, vertical, horizontal, obliquely, just go through the scar to try and create passages in that dense scar tissue. And then I backfill the Kenalog. So I'm not injecting into, but I'm injecting as I'm withdrawing the needle into all these spaces that we've created around, and leave a catheter in place for a couple of days because there is going to be some edema after you do this. And we've had some pretty good results with this technique. We've treated 14 patients of these, and 85% of these patients had, with one single injection, have not had any need for any other treatments for stomal stenosis. We've expanded this now. This is my early results with the 14 patients, but we've done over about 50 patients now with stomal stenosis, treated them in the clinic. Most of these patients do have some diminished sensation, being spina bifida patients, so you can rely on in the office setting. Now, when you do have the superficial complications, most of them, again, are either difficulty with catheterization or stomal stenosis, and you can manage these with a suprafascial revision, can be done as an outpatient. And what we recommend is, coring out the original stoma, making a V-flap and spatulating the stoma to, again, increase the circumference of your conduit to try and reduce the risk of stomal stenosis. Keep in mind that if the patient does have keloid formation or other issues, then unfortunately, those patients will have recurrence rates. One of the other complications that you can manage superficially endoscopically are patients who have early incontinence. And again, before you blame the conduit, you have to look and make sure that the bladder is actually a very compliant, adequate storage capacity. If you have a very small bladder or poorly compliant bladder, that's going to be the reason why your Mitrofanov is failing and not the Mitrofanov itself. So examine the bladder first. So anytime we have a patient who has a conduit where we're having urinary incontinence, we're going to get a urodynamics done to understand, did the bladder change as a result of the surgery that we performed? And if it is, then addressing the bladder first before you undertake any sort of intervention is wise. If you see that the conduit does have low pressure leakage happening, one can try deflux injection. Personally, I've not had much success with that because you inject the deflux, you get continence, but then you repeatedly are catheterizing that stoma and you're remodeling the deflux that was allowing for that extra resistance. And over years, you'll see that the deflux just gets remodeled and then you're going to see a recurrence of the incontinence occurring again. So while deflux or any sort of injectable therapy might give you a short-term outcome in terms of getting dry again, it probably is not a long-term durable result. Some of the subfascial complications can be either vascular compromise, where you have to go and revise the entire conduit, can cause some kinking due to adhesion formation. And so you have to go on, and those are a little bit more involved in terms of managing these complications. But again, I think that the goal of getting these patients independent, catheterizing and being dry, we have to do whatever we can once we take on the commitment of taking care of these patients. So Dr. Mitrofanoff looked at his own outcomes, looking at a long-term 20-year outcome, and there have been other papers that have looked at the longer-term outcomes of these patients. And just quickly looking through some of these issues here, you can see that 43% of these patients in these two series had complications. And the median repeat revision-free survival rate for these channels was about 4 years. Now, when we look at these Kaplan-Meier curves to try and understand what are some of these issues, you can see that most of the complications that we're going to see will present themselves within the first 2 years, sometimes even within the first year of the actual procedure. And as you follow these patients out 5 years, we'll see that we approach those complication rates of about 40%. Most of them are, again, stoma related and not related to any more complicated issues. The revision types, when we look at, what are the risk factors and what are the indications for the types of complications that we're encountering, most of these patients, almost up to 50% of these patients in these two series that we reviewed, had superficial complications. And you can see that over time, this complication rate tends to level out. So after about 3 years, the complication rate will start to level out and won't happen as frequently. The below fascial level complications, again, usually within the first 2 years, you're going to encounter more of these complications occurring. And then again, once the internal anatomy seems to have settled, does not seem to be as much of an issue, which is reassuring. Looking at, what was the substrate used to create these conduits, and does that predict a risk of complications? And unfortunately, in these two series, they did not seem to see much difference between using the appendix versus a Monty or split appendix. Some of the other papers that we reviewed do say that the appendix itself seems to have a higher complication rate with stomal stenosis. I'll also tell you with this personal experience, the spiral Monty or even double spiral Monties, the longer the channel, the more likely you're going to have complications. So, trying to keep in time here because we do have a number of my colleagues who have to speak today. The take-home messages are that, these are not simple procedures. And the longer we use these procedures, the longer we follow these patients, we are going to see complications. And so the first point there is that when you operate on these children, you are making a commitment for a long-term follow-up with these patients. Even with just a Mitrofanoff, you have to monitor them as they grow, as their body habitus changes, that pathway of the Mitrofanoff is going to change. Thankfully, most of the common complications are stomal stenosis and leakage, and most of these complications can be managed either in the office setting or as an outpatient and don't require a formal revision of the Mitrofanoff. When you do have to do a more formal revision, the subfascial revisions were associated with a lower risk of repeated revisions. The safest Mitrofanoff, the safest conduit based on a review of all of the papers that are out there would appear to be a Mitrofanoff urinary tract with an umbilical stoma made out of ileum and without a flap, which is surprising because I would have thought that the appendix would have been much more of a durable substrate to use. But and then I think the last thing I would like to leave you with is that when you're creating a catheterizable conduit, just remember the 3 S's. That the shorter the pathway, the straighter the pathway, and supporting the pathway of the conduit, so that with some sutures to the abdominal wall to keep it from kinking on the inside. So SSS, short, straight, supported, will provide your patient with the most durable catheterizable conduit. Thank you very much for this opportunity to review just, very briefly some of the longer term complications with a procedure that has truly changed the lives of many, many patients that we are able to care for and privileged to care for. Thanks.
Thank you, Pramod. Very nice talk. We may discuss in groups of 3, okay? So
Yep.
we go to the next 2 other talks, and then we can discuss them together. So I'm presenting my talk, which is, as you said, a different way to achieve this same objective. Let's see here. So thank you very much. So the topic that we have today is how we can reconstruct the bladder. Yeah? And the objectives to undergo such an operation, they are related to small bladders in terms of capacity. For instance, in bladder extrophy, in which compliance is not the main issue, but capacity due to leakage. Whereas compliance, which is a problem that we face more in the neurogenic patients. And the problems that you have to control by doing such an operation is to solve urinary incontinence. Some patients present with UTIs, which can lead to renal damages and hydronephrosis. So these are the abnormalities that we can treat by reconstructing the bladder. Posterior urethral valves, which some selected cases may in the future need this reconstruction. Neurogenic patients for sure, myelomeningocele, tumors like rhabdomyosarcoma, extrophy, and very rarely this bilateral urethral ectopia. So we have 2 objectives when we are talking about reconstruction: the choice of a tissue and the choice of a channel. And what we see that we have been shifting to more and more incontinence diversions to continent diversions, which are much more cosmetic aspects. And unfortunately, we know that tissue engineered bladder, they did not come into practice. And we also know the limitations of ureter, stomach. So basically, we have is the use of island or colon, bowel segments. Well, actually, this technique that we are going to talk, we presented as a technique, a new concept in the year 2000 in the British Journal of Urology. But the first case we operated on was in 1998, very soon after I came from Germany, very inspired by Mainz Pouch, by working with Rudolf von Fellner. And then the advantages of this principle you can see in this slide, because the whole operation is made practically outside of the body, and we do not have concerns about the mobility of the mesoappendix, of the of the Monty tube. As you see here, you can very elegantly operate it outside of the body. You see, this is a very thick walled bladder that we are opening. We are connecting the 2 bladders. And it's very important that throughout years, leakage is for sure one problem that we have in reconstruction. But we learned with time there you can minimize these complications by 3 steps. The first step is to provide the serous line tunnel, creating an angulation of the tube downwards. So it's very important to keep this angulation by adding, as you see here in the dome of the reservoir, we are placing a suture above the abdominal wall to keep the angulation downwards. And then we had about 10% of leakage at high pressures at cuffing. Then we discovered this principle from Daniel DaJusta from Jerusalem, which is, I think that Raymond Reckley, actually I saw at first it in a picture of a paper from Raymond Reckley, but then I looked in the literature and noticed that this has been described previously by Daniel DaJusta from Israel, which is a straightforward procedure. It takes us less than 10 minutes to just organize 2 flaps from the recto-abdominal. That's why we always prefer to place our stomachs in midline. And you can make this a narrow sphincter and have it with a very elegant and cosmetic aspect. So here you see that when the bladder is full, it will compress the tube against the angulation and the valve. And this is very interesting because we did this experimental work. It showed that angulation is more important even than the stent of the valves. And this paper has been already cited by Pramod, that we presented our first 10 years experience. It was in 2013 or 2012. And you see that after making some revisions, as about 30%, you can achieve final continence of 95%. But our reductions, our improvements in the continence, they made our complications rate make it small with, I would like to say, with an even better cosmetic appearance. We always do transverse incisions like this, and then you have practically no scars as in the past. This technique is very versatile. These are special indications. Extrophy. I have discussed it last week with Mark Cain in one case. We have just published in the Journal of Pediatric Urology one video showing exactly this procedure for transecting the bladder for rescue cases in which you can absolutely abandon the trigonal and make it a plate and connect to this procedure and have higher rates of continence. In rhabdomyosarcoma as well, we have adopted this technique. At the beginning, we were a little bit concerned about radiotherapy because most of those cases undergo previously radiotherapy and chemotherapy. And so we did a few with transverse column, but after some times we started doing with island, and we have, as you see in this case, with a residual tumor in the bladder neck, and we have no complications at all. So it's safe to do as well, to implant the ureters, as you see here, in the pouch and use the same principle as a pouch. Another possibility of indications that we had, because in the past we had some cases of rhabdomyosarcoma treated with breaker conduits. So in this series, we convert 7 of them, applying the ileal conduit as an afferent loop and connecting it to the pouch with excellent results, as you see here. In some times you get some reduce from patients which are transferred to our department with other operations like Mitrofanov's and Montis, and you can also come and redo this operation. This was a very challenging case from tetrapods, Ischiopagus, that we treated, which presented to us at 13 years with this status. He had a Monti tumor, a Mitrofanov, and a fail in the neobladder, and the water has a successful closure, but was totally incontinent. So in the first case, we tried to just close and use the previous operation, but he had a fistula. We came back, close it, but then we noticed that we had to re-augment the bladder and make it as a pouch. That's what we did for the second twin, that we came directly for a pouch with our principle, which was successful at first. So it shows us that you have the possibility of using this technique in different indications. This is an example of one patient which started anticholinergics and CSC, but Brazil is a very heterogeneous country, and for some reasons he stopped using that and came with such a bladder with high pressures and was not prone to further conservative treatment. I would like to also make a comment here, because since 2011, we have been following from the beginning patients with in utero myelomeningocele operated in the fetal period. So I have a population of 130 patients in the moment that started from the beginning, conservative treatment, anticholinergics, and CIC when they are in the high risk with high pressures. And in this mean follow-up that we have of about 4 years, the risk for operations that, like we're discussing, is about 5%. So that means if you treat these patients adequately from the beginning, at this follow-up we have now, the risk to undergo an operation is about 4%. So then I just want to make you that you can do this operation with a very small incision. Then when you come to major institutions like ours in São Paulo, that we have patients from different parts of Brazil, it was founded in 1950, and it's a major institution in Brazil for neurogenics. They have a lot of campaigns in TV every year to raise funds for this hospital. But in this hospital, the scenario is totally different because they have major orthopedical concerns, as you see here. But you see that even in such circumstances, we managed to do operations with small incisions, with operating outside of the body. Here, we have many patients that were treated in different services of Brazil with vasicostomies, and they were just left, and many of them come to our institutions. We are converting them, as I said, with very different motor conditions. Just a picture, when we started in this hospital in April 2017, in more than 1 year, we did 24 reconstructions just in 1 year, mostly augmentations, others with maces, with poneurotic slings. And for females, we are now using as a reconstruction of the bladder neck, the use of slings. And just to close my participation here, you know that we can apply the same principles using the left column, which has some advantages in terms of reducing the washout time. This was published in 2005 in Journal of Urology. And so, again, that's the aspect that you see from those patients. We published a series of long-term in 2015, yes. And we showed that you have a very nice continence rates, washout times of about 27 minutes, which is less than the classic Malone. My patients normally, they use more than 1 hour. Again, just to reinforce that you can put a piece of bowel outside, make the operation, make the augmentation, do the left thing with the same principle, with very small incisions. For sure, this has been history and something that we learned from our previous colleagues. For sure, Mitrofanov inspired several procedures that we are discussing here. I had the privilege of putting 2 of these names together. And this was our team in the good times. You may recognize here Gilmar Garrone, Sergio Ottoni, Roberto Liguori, Bruno Leslie, several fellows. This is our team, the same team, and this is the most successful thing that I managed over all those years, to keep the same staff for almost 20 years, and that explains these figures that we have. So I would like to close my talk and address Mark for his talk, and thank you for the attention.
That was nice.
Mark, you're on mute.
Can you guys hear me now?
Yep.
Yes,
Yeah.
yes.
Let me share my screen again. Sorry. That was my attempt to keep quiet here during the discussion. Antonio, I enjoyed that very much. I think one of the keys that you were bringing up is making small changes over a long period of time for any procedure that we do, because I think collecting your data is really key over time, because these are, as people have mentioned, quite difficult operations. And I enjoy this kind of a venue where we bring different experiences together and hopefully time to discuss different techniques and opinions. So I have no disclosures other than that my talk today is mostly data I gathered during my 23 years I spent at Indiana University. And I kind of laugh because I tell people I spent my first 13 years there doing all these reconstructions. We collected about 900 augmentations and about 1,000 catheterizable channels between the maces and the Mitrophanoffs. And I spent my last 10 years actually following these patients long-term to figure out whether we did good or bad and what we could do to change that for the future. Because I honestly believe what Chris Woodhouse has said multiple times is that if you operate on these patients once, you own them forever because their problems or their needs never really go away. So just starting with a picture of my good friend Antonio, here he is with our team in Indianapolis a few years ago when we could share time together and hug each other.
Yes, it was lovely.
Looking forward again to those times. But
Yes.
you know, I think the fecal incontinence problem with these spina bifida patients, and we're going to talk just about spina bifida today, I think is really key. They all have problems because of their inherent neuropathic bladder. They have slow bowel transit times. They have poor abdominal musculatures, a poor sphincter tone, and they don't ambulate very well. So it's a timing issue as well as an internal bowel problem for them. And there's lots of data showing this. Their transit time is almost double, 50, 60% longer. So they have hard stool. Most of the medical management is to try to overcome that. And yet you have a poor sphincter mechanism. So it's this a catch-22, as I like to say, because the stool moves slowly, but there's nothing to hold it in place. And these are great medical management. And I think we always start with medical management whenever we're going to consider surgery with these patients. The one in the upper left is from the ESPU, the hospital bone. This is actually a rectal irrigation device from about 300 years ago. So this is not a new problem. You'll all recognize the cone enema. This is the peristine system in the upper right, and then the Chait tube, which actually think was one of the first recognitions that we could irrigate the colon. I was introduced to the ESPU and kind of international medicine by my good friend Rick Rink, and he told me when I got to Indiana, you need to go outside the US to get different ideas. And so this is Salzburg in 1998. This is Paul Mitrophanoff and Pat Malone. And if you look at this is last year in Lyon. Paul Mitrophanoff still has a smile on his face because he's done so much good for kids. Pat Malone was kind of depressed because he thought his procedure may have caused more problem than good. But I'm going to try to convince everybody that Pat wasn't right with that thought. So if you look at when he first described this was a very small series, but it was one of those voila moments where he used the Mitrophanoff principle of a tube embedded in something to create a continent channel and just to irrigate the colon out. At Riley, we caught on to this pretty quickly. This was back in the ESPU in 1999. We used mostly the technique described by many other people, kind of the in situ appendix. The first presentation we had was about 240 patients. And you can see the continence is actually very good that you can achieve with this, but there are complications, the same as Pramod was talking about with the Mitrophanoff. You don't escape problems with these type of channels. So when we followed up on these patients this is a very short follow-up is what I must say, because this was a series where we're trying to just get out and say, is there a difference in the types of tubes? So we had about 236, most of them were in situ appendix. We used a bunch of different types of channels. If you looked at these channels, you can see each of them require a different amount of technical challenge to create them. So split appendix, I think, is a great channel if you can use them, because most of our data would suggest that the appendix is probably the best if you're going to use it. Something other than Antonio's procedure for both the Mitrophanoff and the MACE. They seem to be the most reliable because you're not having to reconstruct like a colon flap or a Monty MACE, some channel for this. And actually our data supported that. If we looked at the in situ appendix, this is complications requiring surgery, both stomal problems as well as subfascial problems. So about 10 to 15% in situ, as high as 33% when we tried to extend the split appendix with a cecal extension. I think this is paper that Tony and I wrote when he was a fellow at Riley. This is the technique I would recommend not using. This was Bill Cromie's cecal extension to try to create a Mitrophanoff. It's great for that, where you staple and extend the appendix on this blood supply. However, you create a angulation problem that you can overcome by using Kurt Sheldon's technique, which is this one right here. And this is the difference between using a dividing stapler versus a non-dividing staple system, where you can create a flap very similar to what Antonio's used for his Mitrophanoff channel. But this has been much more reliable, and I'd say was better than the 33%. But why was Pat depressed at that meeting? It was because of articles like this, and these started as early as 2009. This is here in the Journal of Pediatric Surgery, looking at the outcomes and who was using this. And what they said is that their late failure rate for the ACE procedure was very high, and that only about half of the patients were still using their ACE. We actually didn't think that was correct. And the reason why is if you look at the actually social benefit. So we got very interested in trying to elucidate what was the outcome for the patient as far as their own satisfaction. So this is some of Konrad Szymanski's work. And if you look at urinary incontinence, we're urologists, so we're focused on the bladder. What do parents care? What do kids and parents care about the bladder? Well, they want to be continent and they want to be dry, not just a little, they want to be really dry as they get older, but they care about fecal incontinence. It's an all or nothing phenomena. It's a little bit of stool incontinence is a big deal for these patients. And if you look at the age difference for them, it's very interesting because early in my career, I thought kids should be reconstructed at school age, 8, 9, 10 years of age when they were in school. But when we asked them about urinary incontinence, it actually didn't matter to them until they got into their early teens almost. And this is when the social aspect happens. But once they hit adult life, this was the biggest, most dramatic finding as far as whether or not they were going to be happy or have a good quality of life. So you can see fecal incontinence, on the other hand, it mattered all through their young life. So this is something I think we need to address even more aggressively than urinary incontinence issues for these patients. So the other thing as they become adults is that our kids grow up and they become sexually active, whether they have spina bifida or not. So does it matter to them as far as their sexuality? So urinary incontinence does, but actually it's graded based on how much incontinence they have and how much and how often. So a little bit of incontinence, they still tend to be very non-bothered by that and still are sexually active. But if they have fecal incontinence, their sexual life is very much altered by this because this is 100% dissatisfier. Again, no matter how much incontinence they had. So getting to our MACE procedure, I think just a little bit of how we create them. So this is our kind of way we approach this. So the nurses do all this work for us, just like Antonio was talking about. You have to have a big team to do this. So they all are given this information ahead of time. Here's what we're going to look at doing around the time of your surgery. When they come out, they get this kind of information and we start them on a flush schedule. And they understand this is going to take about a month to get to their endpoint of flush volumes. The other thing that I think is key for the MACE, especially since the stomal stenosis is by far the most common complication, is that we put stoppers on these kids for 6 months. Even if we think it's going to be a really well done, technically well done stoma, a stopper will prevent stomal stenosis in about 50%, which has again been the largest complication that we've seen with these kids. So then what about what you put in the MACE? Does that matter? When we looked at this initially, we went just straight to tap water. We had good luck, but we found that there was a fairly high percentage of kids that failed with just tap water. This is Antonio's comment here. His irrigation on the left, or LACE ACE, is about 20 plus minutes. Ours is about 40 minutes on average. So it does take a little bit longer for right colon irrigation. And if you look at what we had to add, about 20% needed additives to actually get to dryness where they were having fecal continence. And it didn't matter if they were young or old. The other thing that matters with the MACE long-term management is when they have their accidents. So we modify, if they're having immediate accidents, longer time on the commode. If they're having midday accidents, we add additives. If they have high rectal tone from a spinal cord injury, we need to stimulate the rectum. So believe it or not, we set up this algorithm for our nurses. So when there's a phone call to adjust an irrigation, this has been published, they go down this response and it goes into our REDCap database to actually follow these kids. And there's 450 kids now that we follow every year. But if you go through this, you can actually get them to dryness. But boy, this is a lot of work. So this takes a village. And I've always laughed because it takes you about an hour or less to do a mace, and it takes you 20 years to get them to be taken care of during your lifetime and career as a surgeon. So all the people here are the people that do the hard work, which is actually managing the irrigations. So does this affect their quality of life? Our answer has always been yes. And this was Elizabeth Yerke's back in 2003. After we had done a couple hundred of these, we went to look, does this actually provide patient satisfaction? And she looked at about 90 patients. 50% were doing the irrigation independently, which is a very important point for later. And the expectations for the families was met in over 90%. And here's the big deal. So before the MACE, the first 100 patients, they had gone through almost 6 different types of procedures to get dry, the mean of 3.7, but they all thought they were significantly better, almost 90% immediately after the MACE. And Rosalie, when she was about 5 years ago, went back and with Andrew Strine, one of Pramod's partners, we looked at about 120 patients, what changed their life after big reconstruction. And most of them said it was the MACE, actually not the augmentation. And the biggest point, 2/3 said that they could take care of themselves without needing the family to help them manage their stool incontinence. Now, ambulation, actually, these patients, if you break them into ambulatory, non-ambulatory, the ambulatory patients tend to do better. And this is true, I think, for urinary and fecal incontinence, because they're able to actually take care of themselves and manage to get to the toilet better, but they actually tend to have better neurologic outcomes as well. So if you look at the patients and break them down, whether they had a MACE or not, most of them had 0 fecal incontinence. We got up to, again, close to 90% that were very satisfied, just a little smear daily or a few times a week, but still you're dealing with incontinence long-term. This is patients with 7 to 10 years follow-up. You still had about 8 to 10% that were unhappy, but ambulation helped all of them. So the last segment then is, how long is this good for? Is the MACE last forever? And does the irrigation change? So we actually looked at the irrigation volumes, because this is going to equate to time for them. So we went back, looked at only spina bifida patients, everybody under 21 that had it. There were 338 patients in the database. Their mean age was about 7 when they had it done, and we followed them almost for 10 years each. And they presented with what you'd expect. Most of them had fecal incontinence as part of their disappointment about their current medical management. So we had documented MACE volumes on almost all of them. And interestingly, this actually wasn't that interesting. It was what we expected. The MACE volume of the flush goes up over time. So you have to keep adjusting all this over time. So they take fine tuning over time. This is just the 1 year to 5 year ratio. The greatest is in the first year when they start to use it. And I think it's because the colon is still fairly distended. So you have to chase the distended colon a little bit. If you look at the adjusted follow-up time based on the age of their MACE, when it was first done, it actually didn't matter very much. Although if they were done early, they actually had increases almost 100 cc's per year for those first 3 years. So again, irrespective of when they had it done, they had an increase that was almost the same across the time of their MACE. So adjusted for follow-up, if you're doing them at about 6 years of age, you're going to have to add about 100 cc's a year to their flush volume. How about the long-term? Who kept using it in our series? So at this point, we had 413 patients we could assess. Median age was 8 in this group. And again, close to 10 years of follow-up. And that's been our magic number. We want to hit 10 years to know, are we actually following them long enough to understand, is this a durable response? So 92% were still using their MACE at that point, but 33 had their MACE actually excised. So looking at the bowel management after abandoning the MACE, most of them will go back to oral agents. And again, this is associated with the highest risk of fecal incontinence because of their underlying sphincter problems. Some of them went to a Chait tube because they did not want to undergo another abdominal procedure. Some of them actually went to colostomy. And if you look at the reason for banning the MACE, as you can guess, the biggest surgical complication is also the biggest reason to abandon it, which is stomal stenosis, inability to access the MACE. And then incontinence was also uncommon, but a cause for this. And this is, again, Pramod mentioned abscess. You see the same thing with a MACE, I think, that he described with the Mitrofanov. Is you'll get these peristomal abscesses that are sometimes really hard, I think, to manage. So long-term use of the MACE, if you look at this Kaplan-Meier, it never goes away when they stop using it. Just like the problems with the appendix, it never totally goes away. So they drop off a little bit over time. So the longer you have it, if you have it 20 years, we're still at that point expecting about 80%. So this, I think, speaks to another problem that we have to deal with as a group of reconstructive surgeons, is our patients need a medical family at some point. We take care of them like they're members of our family. They become our own children for till they're 21, 22, 23. They need a place to go because we take care of them so aggressively and so attentively, they may not find that. And that's why some of these will fail late. So we looked at this as we built a transitional clinic. How many patients did we lose? And we put our transitional clinic inside our children's hospital, and we still lost half the patients initially. So we actually had to build a transition team. And this is the same group. And I think this is one of the keys is the patients will stay with you if they know you. And if they know you can take care of their problems that they've had all along. So I think in summary, you always, when you're a reconstructive surgeon, have to prepare for dramatic changes because all of these concepts have changed a lot in the 20 or 30 years that this group of surgeons talking today has been involved in this. This is not a smooth path. We have to be able to be flexible, change, and we have to clarify our definitions of success. And I would contend our success should be patient satisfaction long-term, short-term, adolescence, and for adult life as well. So I would tell our good friend Pat Malone, Pat, don't worry, what you've contributed has been a remarkable contribution to kids' outcomes for continence. The long-term MACE is successful, but I think our nursing programs, the surgical aspect of a MACE, technical kind of exercise, it's fun to do, but really the long-term management is what's really key. The patients need someone that can take care of their irrigations, their short-term problems, the potential long-term problems. So the transition is the second key, and never letting the colon really fail where they have chronic constipation, obstipation, I think needs to be our goal. Always end a talk with a fish story. So Antonio, you got to come out to the Northwest because we're going to catch some of these things together sometime.
Wow, it's amazing.
And we're going to have Oregon Pinot Noir, not Caprahenas.
All right.
But again, thank you very much for this opportunity to join this esteemed panel. I always enjoyed discussion with all of you. Thank you so much.
Thank you, Mark. Really nice experiences. Okay. Well, I will let probably the second team to start asking questions for the first half team. And then we can discuss among everyone. And Pankaj, if you have any question as well, you can feel free to pose it. Okay. So would you like to make any comments, Tony and Greg and Daniel? Yes, please.
Yeah, Pramod, great talk. I had a couple of just questions, and it's more of everything's a style with the reconstruction, of course. I wonder, first off, what % of Kenalog are you using when you inject? And how, when you see something narrowing down, how far out from the original surgical date do you think is safe? And then at what point is it too late? The scar's already formed.
Right. So we use the 40 milligrams in so it's 0.4.
Okay. Yeah.
And it comes as 1 ml vials. And I think if you use a TB syringe, that works nicely for that. But the key for success, because I know Dr. A couple of other papers have been written about this, and they haven't had the durable results. And I was talking to my brother, like I said, who's a plastic surgeon. He was like, Pramod, you gotta break up the scar. Just injecting it is not going to work. You gotta break up the scar. So Dr. Snodgrass's paper did not have durable results when he first advocated using Kenalog. But I think the key is to really disrupt the scar with a blunt, larger bore needle, and then backfill those spaces that we created with the Kenalog rather than trying to inject the Kenalog into the scar.
And it's almost like meshing a graft, isn't it, Pramod?
Yeah.
Yeah. I think people missed that point in your initial paper, how important it was, honestly.
Yeah.
And along those lines, it's a balance. I think when we do these stomas, and I struggle in my own head, where you can do the V-flap, and that's how I was trained by Rick. And to be honest, those are very durable. Stenosis is pretty low, but everybody sees it. And then it's like, well, you can create these skin flaps to cover it. And then there's this balance of covering versus having the V-flap. Tell me what you think through when you're doing these flaps, because you've done many of them and the fellows there, and you have this dialogue in your head. We all do when we're doing these.
So I think that, most of our patients have both conduits being created, whether we're doing it or whether colorectal is coming in and doing a Malone procedure and we're doing the Mitrofanov, or we're doing both. So for that reason, we have gone to using the umbilicus for the Malone, and we typically put our Mitrofanoff in the right lower quadrant.
Mhm.
And a couple of reasons for that is, one, I think that for the durability, for me, when I'm thinking of what's the pathway this catheter is going to take and how stable is this bladder going to be, not just for the next 1 or 2 years, but for the duration of the child's lifetime, I think that going to a lateral wall rather than going to the posterior wall, where as the bladder grows, you're going to have more stretch and you're going to change the angulation of that Mitrofanoff if you go to the posterior wall, because the bladder is going to grow in this direction.
Right.
Whereas down low, the lower lateral wall of the bladder really isn't going to change much. So that goes to that short, straight, supported concept of trying to keep the conduits durable. So we choose preferentially to go with the Mitrofanoff to the right lower quadrant. It's a surface level anastomosis. So as you mentioned here, you can hide your anastomosis and get the stomal stenosis down low. Nobody's going to see it, but they're going to experience it when they're cathing. Our stomas are all surface level. You really can't dunk that stoma. The downside is, though, that in some of our non-ambulatory patients, as Mark was pointing out, that the success rates aren't as good in the patients who are non-ambulatory. It's because I think that they don't have enough caloric expenditure, so they tend to get morbidly obese. And when you have these abdominal stomas that are, even the ones in the umbilicus, they completely disappear. You can't see them. So they're doing this by tactile feel rather than by visualization. But when they get a pannus, your stoma disappears and it becomes even more challenging to catheterize. So I think that, all of the techniques, all of the strategies that we deploy during the initial creation, time and growth are enemies.
Yeah.
But at the same time, we want these children to grow. We want them to grow into adults. But their growth, unfortunately, is not as, I was commenting when I was privileged to be Antonio's guest, I was like, the Brazilian children, when they grow up, they're not becoming like our Midwest children in North America. They still maintain that slim, svelte body physique. So their channels, their abdominal wall is not going from this to this. And I think that strains the biological capacity of the conduits that we make. I think definitely affects blood supply, and ischemia causes all sorts of changes in these tissues that we just have to, unfortunately, live with the consequences.
Yeah. One of the other advantages is, go ahead, Mark.
I think another important point is the type of patient you're going to operate on. If you close that bladder neck, you have to ensure you've got the most durable stoma and channel that you can create. And if you think of any mucocutaneous anastomosis, it's gonna want to contract if it's flush. And so you have to, we've decided if we're gonna count on that channel for life, that's the only access to the bladder. The cosmetics take a secondary position to durability. And so, and putting them down low, I completely agree with the approach that Dr. Reddy was mentioning. The reason I put the stoma down low is that most of these kids we're operating on, the bladder doesn't reach to the umbilicus very easily. And I think that, that short, no extravesical distance to the fascia is really critical. If we looked at our late complications, when we looked at the spiral versus Monty versus appendix, we had about 200 in each of those groups. The spiral did the worst because they all went to the umbilicus because they had too long of a channel, and they get worse. I agree. They get worse as the kids get bigger because that channel just grows and grows and grows further away because the bladder is deep in the pelvis and those as they get older. And so if you put it in the right lower quadrant, like Pramod's talking about, you can actually fix the bladder right to where that channel is, and it doesn't change over time. And I think the durability in our series of that 600 series or so, where the appendix was far better for subfascial revisions, was because of that. So I think it's another reason to consider doing it.
I'm going to be speaking about the double umbilical stoma shortly, so I don't want to get too far ahead.
Okay.
I would say that my experience has been different, and I think that some of it is selection criteria, and absolutely the bladder to umbilical distance is critical. And with that in mind, what I've found is that the best patients are the prepubertal patients. So once you have a prepubertal patient, and I do fix the bladder, I do perform a hitch, but I use PDS, and I'm sure it wears off over time. But what happens is it allows the bladder to heal, allows the channel to heal. But I've had patients now for 12 plus years, and I've never had a patient with a challenge with catheterization. I've had some stomal stenoses, I've had some ACE leaks, but I've never had a patient that cannot catheterize through that channel into the bladder.
You're not waiting long enough.
Yeah.
Well,
Yeah,
I just want to comment that I think very closely to what Mark and Pramod said. The difference is that through our concept, our stomas will be low but midline, probably because you are using the appendix. The most favorable site is lower on the right side. But when you have the tube going out from the reservoir just to the skin, and I use a variation of the V key, which is a semicircular incision. And honestly, strictures has never been a problem for urinary conduits. For the laces or left sides, for sure the stopper has reduced dramatically. But for those patients, I had some loss in terms through after puberty, which I don't see in the urinary conduits. So
I wanted to also just throw in a comment about umbilical versus lower channels. We have a reasonable group of patients that would not be classic candidates for metrophenophenase, high cervical injury patients that undergo tendon transfers. So the location of the channel is critical. And, you've already said that the functional outcome is really, obviously a low channel if you think you have durability, but you're not going to have the ability and you're not going to have the independence that you're going to have with a higher channel. The other thing that I would say is that the passage, the depth, yes, you do have greater length, but you're also with obesity. If you place a channel within the umbilicus, abdominal wall girth occurs above that area of the channel, not to the skin, not versus if you put it to the skin lower down, you're gonna be stretching that thing more. So I think actually the fixed length issues are more challenging if you have obesity in a lower position.
It's interesting, Greg, because when you talk about never reoperating, and we've got about 700 channels now that are down low, and it didn't matter where we put them for late complications, unless you had a distance that you were trying to overcome between the fascia and the bladder. So I think that's really, really critical. But I don't think I ever remember, I've done about 250 of these channels and followed them for about 23 years. I don't ever remember having to operate on somebody for a suprafascial angulation problem. Subfascial, yes. Stomal stenosis, yes. So then when they get fat, as long as you have it in line with the fascia, there's three hinges, right? Skin, fascia, and into the bladder where you can run into trouble. I don't know if I've ever seen it in the sub-Q where they have trouble, except for these rare instances where they perforate it. And I don't think that happens very often. But I agree with you 100%. I've had a couple of C-spine injury kids. I put them all up high, but they tend to have really big bladders too, at least in my experience. So you can get the bladder up to the umbilicus and they can feel it and put it in. I'm talking, when I was relating to what similar as Pramod, most of our patients are really obese, I think, even when we operate them. We're not, and I went down and did one of these with Antonio probably 10 years ago. And I looked at his patient, and I'd never seen a patient like that. She was flat abdomen. and most of our patients have a BMI of 30 by the time we're operating them. We're not operating them at 8 or 9. We're operating them at 11, 12 a lot of times now. And they're already bigger. And so I think we have these different technical things that are maybe unique to different areas in the world that are different.
There's a lot of fat people in Philadelphia. Don't worry.
Yeah.
One of the other,
I may address a question to you all, guys. Yeah. You have, it's not more so common as in the past, but in our institutions in Brazil, sometimes you still have patients that came to you. And I remember the Mark, he was, when he came to our university and we were seeing cases after the operation, he saw just coming a boy with 5 years of age, we absolutely a bladder not prone to any further conservative treatment. I know that you see fewer. I see fewer in my office, but I see still in the hospitals we work. So my question to you, would you go to reconstruction or would you make some incontinent diversion? Because all the times that I send papers, I see a lot of people saying this. Oh, you should divert it and then later decide, which I find absolutely not what I do. I correct them, and the results. I have a paper that I published with 30 cases operated under 5 years of age, and the results were the same. And when I look them back for long terms, they still have the same equivalent to older patients. So I'd like to know your opinion.
So I think that, as reconstructive surgeons, I think the mantra should be that our care has to be devised as being patient-focused, family-centric, and I would add another part, which is culturally appropriate to where that child is going to be living. Yes, we do have, I think all of my colleagues here on the panel, we have patients that come from afar to come to our institutions for care because of the reputation of the institutions and where we work. And but they're not going to be living in our backyard where we can continue to take care of them. So if someone's coming from a different country where I know that the safety net that Mark was talking about, having that entire team there to take care and answer the phone calls and troubleshoot with them, if we don't have that luxury, doing a state-of-the-art operation on this child is the worst thing that I could do, because I'm going to condemn this child to bad complications, and my colleagues who take care of this patient in the area that they're from aren't going to be able to take care of them. So, I'd really have to tailor my surgical strategy to where that child is going to be living eventually. So I really think that those are the three things. What's going to work for that patient? Can the family take care of what we're going to be doing for them? And then can the medical environment and the community that this patient is eventually going to grow up in handle what we're doing? And I have done more and more lately incontinent reconstructions when I think that I need to protect this patient, because I can't live with myself if I know that I have caused damage to a child's kidneys or overall health.
So Antonio, I think there's two things that have happened. One is that augmentation got a really bad rep in the United States, maybe in the mid 2010s or so, because of associated complications. And I think people shied away from it. If you look at the augmentation rate, it went down pretty dramatically in our national databases with all the children's hospitals. And the other thing that happened almost at the same time is that the kids that got augmented in the 90s became adults, and our adult colleagues that were taken care of before we had transitional care were undiverting them to ileal conduits. And so there was this two pressures pushing us to avoid augmentation, despite the fact that that's where a lot of them will end up. And then the third thing is this competing argument that medical management can compress the need for augmentation pretty significantly. So you have to give them longer to fail. And it's pushed our age of augmentation. I don't know what I'm interested in the other panelists, but the age of augmentation used to be 7, 8, 6 to 9. I would say now it's probably 9 to 12 in the United States because of these competing factors. Now, personally, I think if you're going to end up there eventually, is there a difference between a 6 or 7-year-old versus a 9 or 12-year-old? I don't know the answer to that, honestly. But we do know the families are more, at least in the United States, they are more involved, and they will accept that long-term complication risk panel or profile for the patient once we've gone through everything. So it may be a little bit cultural, I don't know. But those are you've seen that in your career, because all these competing things that you see in the literature and in the meetings has really created an impact on families, because they see all this literature, and us as reconstructive surgeons, our ability to go straight to a major operation, I think.
I think that one thing is a bridge of Botox. So Botox is kind of in a bridge, and that's also played a role in timing of reconstruction also.
Well, I think one of the things that we don't have, and I totally agree with Pramod, we have to focus on the patient, focus on the family. We know what the results can be when we do a big reconstruction, but what we don't know is a way to measure, is the family ready? It's a tool that can measure, is the family ready for the big reconstruction? Is this a good family? Is this not a good family? Is this a good family for an incontinent diversion? I mean, we can sort of predict, but really we can't. I mean, we're trying to work with our ARM population here and seeing if we can figure it out based on the socioeconomic status, educational, and different sort of family-related factors. Which family is actually perfect for the big reconstruction, and which one is actually better suited for an incontinent diversion? And it may be 50-50. And it's like, and then truthfully, to what Dr. Cain said, if we do have a family that is ready for a bigger reconstruction, it may be better just to do the whole thing with the augmentation as early as possible, because they're going to be good with that. But if you do, and I hate saying that, if you do a good operation for the wrong family, you're going to end up with the worst outcome possible. And we don't have a really good way to predict. That's the problem.
Yeah. Good. Nice comments. So I would like to go further for the second half of our talk and invite, let me see who is the next. Oh, yes. Okay, Tony.
Yes.
Bladder neck, also
Got it.
very controversy topic as well.
Yes.
Yes.
Let me, let's see. So what do? I share.
You share your screen.
Yep. All right, and then.
There's a green yes button. Yes, perfect.
Okay, and you guys can see, and then I'm gonna do my. Perfect, everybody see?
Yes.
Okay, great. So with this work, I would like to thank my mentors, and for reconstruction, that obviously comes from Indiana. So one of them's here, the other's Rick Rink. And, you know, as you alluded to, bladder neck repair is very controversial, and we have a spectrum from injection therapy all the way to bladder neck division. And so what I thought I would do is when we're thinking about urinary incontinence, of course, there's two components. There's the compliance of the bladder and the resistance of the bladder neck or urethra, and those two together create your issue with incontinence. And so today I'm just going to focus on urethral resistance and understand that this is integrated into the compliance of the bladder. Many of these kids are simultaneously augmented, but we're going to just focus on the technique, assuming that we all understand the latter. So factors to consider when we're picking patients that we think may need a bladder outlet procedure are their ability and their desire to void and their level of bladder compliance. One thing that we always teach our fellows and residents is that you should never achieve continence at the expense of the upper tracts. It alludes a little bit to the comments that we were just speaking to with respect to compliance of the families. Up to 1/3 of all the patients that undergo just a bladder neck procedure, be it a tight wrap, a sphincter, will eventually need upper tract, will have upper tract deterioration, and they'll go on to need bladder augmentation. And although we tried, even when I was in Indiana 20 years ago, to look at pre-operative urodynamics, we found that it's just not predictive of those patients that undergo deterioration. So with that respect, surgical procedures that increase bladder outlet resistance include a number of techniques, the flap valve creation or urethral lengthening, the injection of bulking agent, slings, and then finally artificial urinary sphincter. So first we'll focus on flap valve creation and urethral lengthening. This all began in 1919 on a principle founded by Dr. Young, where he in essence incised the bladder neck up towards the trigone and just literally tightened the bladder neck. Adding to this was Dr. D's in 1949. He extended or had some urethral lengthening within the bladder, and then Ledbetter extended onto this by moving the ureters up higher in the bladder to further lengthen the urethra within the bladder, in addition to tightening the bladder neck. Most of us know that the tighter you make the bladder neck, the more you're mandating intermittent catheterization. This has classically been used in bladder exstrophy, which it does allow for voiding, but the tighter the urethra and the more narrow the urethra, this does decrease. In terms of outcomes, the Indiana group presented the largest series of the Young D's Ledbetter. They looked at about 40 patients. Most of those were girls. 30 of these had a bladder neck repair. 6 of these were secondary. And in 8 of these, they were placed in a silicone sheath at the time. And the thought there was to create this biofilm and resistance. They found that to achieve continence, most of these patients, if not all, required bladder augmentation. And the urethral sheath was abandoned because over 50% of those patients developed erosion from the sheath. Now, others have described urethral lengthening, the crop procedure. All of us know the anterior detrusor tube. This relies on tubularization and then reimplantation is described here in these pictures that Dr. Rinks allowed me to use, where you have an anterior bladder tube and then it's tubularized. A tunnel is made in between the ureters. This is brought through the tunnel. And so then you have a mechanism to lengthen the urethra and then potentially catheterize the patient. In reality, most of these patients that have a crop procedure are having a simultaneous catheterizable channel created. Now, the largest series here is by Warren Snodgrass. He presented on 23 patients with the urethral lengthening procedure, a crop procedure, and achieved 90% continence. Of note, however, half of these patients had reflux after the procedure. He speculated that this was due to the lateral displacement of the ureters as you're tunneling the channel, although it's unclear if this was due to elevated detrusor pressure as well. Pippi Sally, again, the same principle, but you're doing in essence an onlay with the anterior bladder tube, and then you're just suturing it down onto that central portion. They achieved a continence in 71%, and others have increased that continence rate the tighter they make the urethral strip. So if you make this down to, in essence, all but dividing the bladder neck by making it 8 French, then they have an increase in continence. But again, this is a balance. The less that you have a pop-off valve for leakage, the further risk you're placing the upper tracts to deterioration. So moving on to bulking agents, the principle behind this is to achieve coaptation. And so you inject submucosally, circumferentially to try to coapt the urethra. It should be noted that several agents exist, but bovine collagen should be avoided in spina bifida population because of the crossover with the latex allergy. Dextranamyr hyaluronic acid or deflux has been used in some with success with multiple reports. Greg Dean, who's on the panel here today, reported a number of years ago that combining a antegrade approach and a retrograde approach appears to increase success with injection therapy. In terms of continence defined as 4 hours of dryness, there's a huge spectrum, anywhere from basically none, 5%, to about 80%. But what's clear is most of these patients require large volume and repeated injections. And if they're catheterizing through this area that was injected, the continence does decrease. Early success equally tends to decrease and lead to a formal bladder neck repair if you look at the literature. And if you're looking at bulking agents, probably the best application is after a bladder neck repair used as a rescue technique or to supplement the resistance created by the bladder neck repair. So moving on to sling procedures, again, the idea here is to circumferentially or to compress the urethra or the bladder neck and to elevate the bladder neck. So you're changing the angulation. And when you do this, you do create a number of issues where you potentially could prevent the patient from catheterizing via the urethra. And a lot of these patients are having concomitant catheterizable channels. A number of products are available off the shelf, SIS, Gore-Tex, autologous fascia, and native fascia. So native fascia, you can use kind of a horizontal strip or vertical strip, 1 centimeter, and the appropriate length. Again, wide range of success from 55 to 100%. And most series report concomitant bladder augmentation. So it's tough really to sort out with slings what the overall continence rate is. And that's something that we find throughout all the literature with bladder neck repair, that it is somewhat skewed because a lot of these patients are having bladder augmentation. Now, if you look at the literature, there's only one report of success of bladder neck slings in the absence of augmentation. And the reported success is about 80%. They felt comfortable with 35% of patients having detrusor pressures greater than 40 centimeters of water. They developed hydronephrosis and reflux, and some of these they corrected with injection therapy for reflux. However, if you look at the same population long-term, 70% of these patients required additional procedures. 30% of this population required augmentation. And unfortunately, 20% of this population developed chronic kidney disease. So it's not really recommended to have sustained pressures elevated at that degree. And I think most of the panel would agree with that. So in terms of slings, success for slings increase with female gender. If you have a neurogenic etiology, and interestingly non-ambulatory, I think because the angulation issue is not changed. We started using a circumferential wrap, a 720 wrap. Actually, David Joseph calls this the bender. And again, same principle, compression, and then you either tack it to the fascia or you tack it to the pubis. This is combined with a catheterizable channel. So bladder augmentation, as I mentioned before, is combined with about 70% of these patients in the literature. This does mandate intermittent cath, and it affords you the ability to make the sling very, very tight. So finally, moving on to the what I view as the ideal bladder neck procedure is an artificial urinary sphincter. Now, historically, the sphincter was placed around the bladder neck, and this in the younger population, so prepubertal population, both the female and the male. To gain access to the bladder neck, this can be gained anteriorly or posteriorly, where you take down the peritoneum, and then you can develop a plane either in the female pushing down the vagina, or certainly pushing the anterior rectal wall down in the male. And you can gain access from behind this way as well. Should be noted, up until the mid-90s, the pre-800 model required the surgeon to actually put together the pieces and tie knots to connect the device. The 800 model now has these quick connects, which allows a tool to connect the tubing with the reservoir and the pump. This has significantly decreased the mechanical complications associated with the artificial sphincter. And this is the 800 model here, and this is the latest generation here with the reservoir, the cuff, the pump, and these quick connects. This does make revision very straightforward as well, as you can increase the reservoir side by clamping and reconnecting here, or the cuff if you need be. Most of the patients that have a bladder neck cuff, we use a 4.5, and that's just something that most of the kids have about the same circumference around the bladder neck. So when I was a fellow, I had the pleasure to dig through all the microfilm to look at all the patients that Mike Mitchell and Rick Rink put an artificial sphincter in. And so this is kind of my, I won't call it an albatross, but I did put a lot of time into it. So this was 142 patients that I eventually was able to track down. And we had some great data from this review. 80% of the patients were dry, and this is bone cold dry, so like complete dryness. 18% improved, and that's that window where you get over 4 hours, you leak. And only 2% of those patients were wet. So the take-home message here is that when the artificial sphincter is functioning, you're dry. Now, in terms of mechanical complications, I alluded to with the quick connect, decreased this significantly. So the overall complication rate for the pre-800 series was 64%, about 1 per every 12.5 patient years. 800 series, about 30%. And this is 1 per 18.2 years. Now, when I was in Indiana, Dr. Mulcahy had a saying that it's like a refrigerator. So it's a mechanical device. And so the more you use it over time, it eventually is going to break down. And I kind of use this in a way when I'm talking to the patient. So I would say it's expected in almost all patients, especially if you're putting this into a child. They should expect at some point you're going to have a mechanical failure. In terms of surgical complications here, 24% required surgery for the complication, and this would be an erosion and or an infection. Interestingly, there's no real difference if you look at the pre-800 and 800 series, and that would make sense. They didn't really change the cuff, they just changed the ability to connect the tubing to the reservoir and the cuff. Secondary bladder augmentation, again, these were mainly placed in patients that voided spontaneously that had compliant bladders. So 20% of these patients followed closely over time, went on to have bladder augmentation. And that is similar to and consistent with the literature for these other bladder neck tightening procedures, urethral lengthening, the crop procedure, the sling data from Dallas, very similar. Now, one of the issues is you can have a leak in the cuff. This can cause the fluid not to compress the urethra. You can have breakage in the tubing. And again, this has been ameliorated by the Quick Connect. And this is the pre-800 model, as you can see, where you had to actually sew the two together. And you never want to see this. One is a latex catheter in a spina bifida patient, but the other is you never want to see the urethra and you're putting the cuff around it. So this is an erosion. And in females, you can have other complications where if you're not careful when you're dissecting, you can actually dissect completely circumferentially around the vagina urethral complex. And so you have to be very careful. And I usually use the posterior approach to avoid the inadvertent circumferential wrap around the vagina. Now, for the artificial sphincter, if you look at advantages, without question, it achieves the highest rates of continence. It's the only bladder neck procedure that is expected to allow spontaneous voiding. Now, I know that the young bees Ledbetter may as well, but just for the purpose of this discussion. Furthermore, work that we did when I looked at these patients that were older, it became clear that the artificial sphincter was not being cycled. There were two groups. One is the fluid leaked. The other group is the patient, when they became adult, they had a catheterizable channel created and bladder augmentation. So they quit cycling, although it was functional. So these were what Rick termed non-cycled artificial sphincter, two groups. One, it leaked, the other, they just didn't cycle. And that didn't appear to be a problem, did not increase erosion, and it appeared to create a biofilm around the urethra, kind of like the sheath that they looked at in the 1980s. And it allowed enough resistance to maintain dryness, even though the cuff had no fluid in it. And equally, the ones that it did, not cycling, did not appear to increase urethral resistance. So there was some good data from that. And I think the ideal patient is one that demonstrates a compliant bladder and has decreased outlet resistance. And the ideal patient, in my mind, would be the female epispadias, although we certainly have others that fit that bill as well. Now, the disadvantages, I alluded to this, mechanical device that will require revision in a significant, if not all, patients. If you look at the largest series, and again, we followed these kids up to 16 years, there was not a big difference between the pre-800 and the 800. Not a big difference between the AUS, which is about 30%, and the large series that is presented from Indiana with eventually you will require another operation. That's about 34%. So in the big picture, it's very similar. It is a foreign body. It is always prone to infection, although this decreases after the biofilm formation. And most importantly, up to a third of these patients will require bladder augmentation due to upper tract deterioration. So finally, bladder neck division. This is the ultimate bladder neck procedure. You're in essence converting the patient to a continental urinary diversion. To perform this, I won't get into the technique, but you have to aggressively mobilize the bladder, placement of a barrier, either a rectus muscle or omentum to decrease fistula formation. And interestingly, there were concerns for long-term failure due to lack of access to the bladder, but the literature doesn't really bear this out. So it is very interesting that I think through education and the safety net and application of this procedure to the correct patient, it appears that looking at the literature, we haven't had the major complications that certainly some would expect. So in summary, I put this table up to in essence summarize, if you pick a procedure, then you have an expectation with respect to voiding. Without question, artificial sphincter gives you the highest chance of voiding, and certainly bladder neck ligation gives you the lowest chance. In terms of continence, again, the artificial sphincter over the flap valve or the sling, I think injection therapy is very low. In terms of upper tract deterioration, though, the injection therapy probably has the least risk of upper tract deterioration, whereas the sphincter and bladder neck ligation are very high. And in terms of revision, I think this is consistent throughout the main group, but probably the highest for injection therapy for failure of the ability to achieve continence or the artificial sphincter just due to mechanical failure. Thank you for the time, and I hope you guys enjoyed that discussion. Again, I could talk on bladder neck repair for an hour and a half, but that was just a kind of a high level summary. I do have specific knowledge with the sphincter group, as I've spent countless hours reviewing those charts and spent a little bit more time on that group.
Great. Great family seeing basketball. Was that?
Yeah,
Tony?
yes, basketball. That's
so
real.
nice.
That's what we used to do, and have
Yeah.
people up here to watch the game.
That's great. Good. So thank you very much, Tony, for this review of the artificial. We may have some questions
Sure.
after the second block, okay? But let's call Greg for
Okay.
his contribution.
Okay.
So you have to unshare your screen.
I'm
so
sorry. Yep, I'll do it right
that,
now.
yeah.
New share, is that right?
Unshare.
Where is unshare? Stop share. Got it.
Okay.
Yes.
So I'm going to share screen.
All right.
Can you see?
Yeah.
Yes.
Perfect. Let's go to this from beginning. Okay, great. So this is actually adapted from a talk that I gave 3 years ago in Barcelona. And again, thinking back to where you give talks really reminds us tremendously about what we've lost right now. But basically, I want to discuss our experience with a double-barreled umbilical metrophenophenase procedure. And I think this really relates to what was being discussed earlier with the esteemed panel about preferences, about what you experience locally and your results. And while our numbers are certainly not as great as the Indiana group, I think we've had some great results. So when it came to the double-barreled stoma, this really is born in some ways of when you're working in isolation, you sort of adapt to other people's techniques and your own spin on it becomes something unique. And really, as I first looked at the split appendix, I thought about where do I want to put the stomas? And then I really decided that I didn't want to separate the mesentery, and I wanted to make this simple. And so with that in mind, I really, it was a very short step to making these stomas adjacent to each other. And I think ultimately the benefit of this is it's simple, it's reproducible, and there are, I think, benefits both functionally, that I do think that an umbilical stoma is an easier stoma to catheterize based on the distance and based on Pannus issues that you have with lower quadrant stomas. And I believe that there is a cosmetic enhancement to an umbilical location. So we looked at our patients going back to the early 2000s, and of those, we had 15 patients who underwent this procedure with the age ranging from 4 to 14 years, with a mean age of 8 years. And again, like all of these things, patient identification is critical. If you have a patient that is tall, a patient that's old, a patient that's post-pubertal, this is not likely the ideal patient. And just like we know that with open ureteral reimplantation, prepubertal patients are simpler to operate on than postpubertal because the bladder is an intra-abdominal organ. And with increasing growth, the bladder tends to drop down into the deep pelvis. And the distance then between the bladder and the umbilicus increases. Furthermore, over time, you may actually have deterioration in the bladder, and the bladder then becomes more problematic with regard to doing this. The other thing that I focused on was that over time, we switched from a midline longitudinal midline incision to a fan and steel incision. And with this fan and steel incision, it became more beneficial to identify that the appendix was viable and usable. And if it was, then I would make a fan and steel incision. But with this in mind, it then became imperative to create the umbilical flap prior to placement of the laparoscope. So this just shows basically, this is a patient that actually did not have a fan and steel incision, had a longitudinal incision, one of the earlier patients. And here we split the appendix from an extravesical approach. And there are different ways of creating this double umbilical stoma. But in this instance, I have a longitudinal incision, and then I have basically my double umbilical flaps. I raise the flaps, raising them here, and then I place the channels within this. And you get again, simple, easy. This is actually, I'd like to make a comment regarding Pramod's use of the Pannel. I'm just noticing here that this kid actually had a little bit of a hypertrophic scar post-procedure. So this is another area where you can consider Kenalog. Whenever we see any of these or penile scar, we'll use Kenalog freely, and it works extremely well. So I think, again, just a shout out to the use of Kenalog. This is a brief video that we presented in Spain 3 years ago that I hope you can see.
The patient is an 8-year-old boy recently adopted from China. He has neurogenic bladder and bowel. He's unable to tolerate penile catheterization. A subumbilical incision was made in order to facilitate diagnostic laparoscopy to confirm the presence of an adequate appendix. A fan and steel incision was made incorporating the inguinal hernia, which had previously been repaired. Dissection was then carried up toward the umbilicus. A midline longitudinal fascial incision was then made to facilitate entry into the peritoneum. The appendix was isolated. A holding suture placed through the distal tip. Attachments from the mesoappendix were taken down, facilitating complete exposure of the appendix. The appendix measured 12 centimeters. The distal tip was sized, and the appendix then divided after confirmation of catheterization. The appendix was irrigated. Both channels are exposed. The bladder was then dissected. An extravesical reimplantation was performed. The fossa was then incised, and the bladder trough closed over the appendix. Catheterization was confirmed. The channels were then brought up into the region of the umbilicus through the prior port site. Cecal tissue was then imbricated over the Malone channel. 2 incisions were made to facilitate creation of the stomas. The base of the umbilicus was left intact. The Mitrofanov was then spatulated and matured. The Malone channel was brought up and was also matured. Both channels easily catheterized. Mitrofanov demonstrates good drainage. The Malone channel easily was catheterizable. This is the post-procedural image. The patient was discharged home on postoperative day 3, and now 3 months later is cathing both channels without difficulty.
So, like all procedures, things evolve, and since that time, and it wasn't demonstrated in that presentation, but we will make our channel flaps prior to placement of the laparoscope. And the reason why we place a laparoscope is because I want to make sure that I have a good appendix before I make the pannel incision. If I don't, then I'm more likely to make the longitudinal vertical incision. So what's our results? We've had 14 patients. 13 of the 14 continue to use both stomas without leaking. We had one ACE channel that became problematic. It was difficult for him to catheterize. And ultimately, his fecal continence improved and basically abandoned that channel. What I have found is that when you're dealing with this, you're basically robbing Peter to pay Paul when you're doing this. You have to decide how are you going to allocate the appendix with regard to, are you going to give it for the Mitrofanov or are you going to give it for the ACE? And so because urinary incontinence is more difficult to manage with these channels than fecal incontinence, I basically give the majority of the length to the Mitrofanov, and I have a very short ACE channel, very short. And I will tell you that I tell families ahead of time that if I do get any fecal leak, I'm not going to be surprised. And I found 100% success rate. We had 4 of 15 that did develop fecal leak, and they all respond to deflux. It's very simple. I bring them back a few weeks later, and I inject a little bit of deflux, and they're continent. 4 of the 15 have needed stomal revisions. None of the patients. One of the concerns is that with these channels being so close together, are you going to see increased urinary tract infections? And while this is more anecdotal from my perspective, because we haven't tracked it in any great detail, I haven't seen what I believe to be an increased rate of urinary tract infections. And the families are very happy and proud. I've had families that come back to me and they go off to a camp, like a spina bifida camp, and the families are shocked when they see the stomas. They're like, how did you get that? Where did that come from? And so people are happy and actually very proud of these channels. What are the tips and tricks? Again, this issue of the bladder, if you had a very hostile bladder in an older kid, it's not going to be possible. And I would agree with Mark and with Pramod that these channels would then need to be placed in the lower abdominal area. Consider a Banasteel lap approach. I think that's a better approach. Make the umbilical flap prior to laparoscopic access. Again, when you're choosing what segment to use, I would use the appendix for the Mitrofanov over the ACE. If there's any issue with distance, I'll hitch the bladder up a little bit, and then be prepared for ACE leak, which is again easily managed with deflux. So this procedure, the double umbilical flap, it's easily performed, particularly in younger kids. Our results, while we have a very limited series, they seem very favorable. We have had patients that we followed for over 12 years. And I try to implement this as early as possible. I don't want to have a family that's on the fence come to me at age 15 and say, they want this. I want to do this when the kids are prepubertal. So thank you.
Thank you, Greg. It's an interesting alternative. No? It's a very clever step with the limitations of indications for sure. And I like that you select previously through laparoscopy to see if they have a big appendix. No?
Yeah, because then you're not fooled. And I think the other advantage, I believe, is that, when I see what appendix approaches, and I really separating out that stoma, I think you do have to mobilize the mesentery. I think this is much more of an in situ approach. which I think puts less stress on the appendix. And I think maybe that's one of the reasons why we've had a pretty good result so far.
Yeah, very nice, Greg. I really enjoyed the presentation, the video. I wish we had more appendices like that were just long enough and had a beautiful middle.
People say that, and maybe
appendices are like twisted and short. That's
stenotic at the end. Yeah.
Well, that's why I said you don't want to get in there, make a fair and steel incision. See, I'm going to make this beautiful, and discover you have a problem. So that's the advantage of making the laparoscopic inspection, so that you're not burning any bridges and you're prepared to do whatever you need to do. And I would say for sure, there are situations where I look at it and say, I'm not going to do this. But I will say that operating earlier, in the majority of instances over recent years, if their patients are a candidate.
Sure. Yeah. When I first came here to Cincinnati, Dr. Sheldon had just, started perfecting the technique of the split appendix as his modification. And we would do both stomas in the right lower quadrant, because again, same concern, not mobilizing the mesentery too much. But lately, when we split, we're able to we mobilize the cecum and move that medially, so it's in the umbilical region, but we still put our distal end of the appendix down in the right lower quadrant, so splitting it. But I like your approach. I think cosmetically, that's a beautiful result you're getting.
Thank you.
I noticed, Greg, that you didn't do submucosal tunnel in your ACE. I would like to know about you other guys, because I always, when I do typical ACEs, I always like to make fenestrate the meson, open a little bit the ceromuscular, and put some stitches. How do you do it? Or you just rely on the valve?
I try to I try to at least put a couple of stitches in to your point, but I know some of our pediatric surgical colleagues, Karen West in Indiana, who did a ton of these, she would just pull the appendix up and say that if you leak, it's due to lack of irrigation, non-compliance. And I don't know if that was a convenient answer or that's real, but it has allowed me to shorten that little appendiceal stump and feel fairly good. And to be honest, I don't see any leakage, even when I know it's like 2 centimeters. And I'll put a couple, maybe one stitch. Mark taught me to wrap kind of a cecal wrap around it, kind of a buttress, and then you sew that up anteriorly. And so I don't know if that helps, but I certainly think that compression, but the irrigation, I think, is the key.
Well, Tony, your comment about that, I think that I have heard people say this, that the experience with a LACE procedure overall, if you look at the results, where you're not doing that imbrication, that your continence is equivalent. But I've heard some people say that during episodes of diarrhea, that you may see a greater leak rate. And I don't doubt that what I'm doing is a compromise in terms of my Malone. And one of the reasons why I can do this is because I accept extremely short Malone channels. And I rely again on this concept of using a bulking agent. I've always been interested in bulking. I've used bulking for bladders, but as you said, it doesn't work that well. But where it works,
Tony, don't go there. Don't go there, Tony.
It works. It is an ideal. I think that deflux is an ideal application for a short ACE channel, and it gives you the flexibility.
Great. Greg, have you done any cecal extensions when they're real short like that? Just stapled extensions?
I have, and I've done that again where you do not split it.
Yeah.
Put a channel of staples and extend it. But what I found was that I didn't, never with the split appendix, always with other applications, and I was doing that earlier. But what I would tell you is that sometimes I would have channel issues trying to get the catheter to pass easily, and this eliminates that. So I've abandoned doing that. I haven't found the necessity.
So if you look at the general surgery literature where they don't necessarily imbricate and intussuscept like we always have kind of overdone, they have about 10 to 12% leakage, but they don't use deflux like you're describing. And so they end up with those channels intubated long-term more often than what we see in our literature. So they get ostomy tubes in tubes put in them. And I think that is a disservice based on the results you've shown. They're cosmetically really outstanding. So I think whatever you can do to get it dry, I think is improvement.
Tony, can I ask a question that's a little off script?
Yes, for sure.
I have a couple of patients that have come in, and I know that you all have this challenge where they come in with a Chet tube. And
oh yes, there was. I was going to ask you.
Yeah,
because there is a chat question here from Dr. Bernardita Troncoso. So
and they want a mace, so then they want you to convert to a channel, right? And so one of these patients laparoscopically, I stapled the connection. Basically, they had a colostomy. I stapled that and then just created a flap with a linear stapler and brought that back up. But I wonder if maybe Mark or Pramod or Daniel, if you could comment on that. You're at a high volume institution where those patients do come in. They've been seen by ped surgery. Now they want this channel. What are your options to the patient?
A lot of here that what we do is eventually, a lot of those patients have already had their appendix used for something else.
Exactly.
And then you're pretty much left with the option. And I find that very interesting what you did. But often our colorectal often have been very successful at doing cecal flaps or the Macedo flap. And I found that when I do that laparoscopic too with the robot, it's pretty straightforward to do. And we normally create it pretty easy based, you can see the blood supply on the wall of the cecum, and then we do imbricate that. Similar to trying to create a valve, the colorectal surgeons here are quite into creating a valve and do not like their regular colleagues that before them didn't do that imbrication. Right. And I have been successful actually. Now I've been coming busy because every time they have a leaking cecostomy, they've been calling me to inject deflux. And it has been working, but indeed, I had just created myself a whole new niche with the pediatric because they don't know what to do, so they want me to come and inject their deflux. So
that's why I was asking the question, because this patient's created 3 or 4 that come in, and then the more you treat, then you're creating this population, right?
Yes.
Another strategy is that Brian Vanderbeek and I have had a number of these patients where we've gone in and looked, and the appendix that had been used either for Mitrofanov before was long enough that we could actually take it down, split it. So we, and again, like Greg said, our tolerance for how much of an appendiceal stump do you need to leave on the cecum to facilitate an appropriate Malone, we're down to 1 centimeter. But unlike Greg, we do use Dr. Sheldon's technique of a non-cutting stapler.
Linear, just
wrap, and that's something that Dr. Sheldon taught us, is that the continence mechanism is important. I think Dr. Pena and Dr. Levitt, when they were here, did an experiment where when they were doing these procedures, making the maces, they would have one of them pinch off the cecum, and they would put a catheter in and fill the cecum with saline and see if the appendix was going to leak or not. And they showed that 30% of the ileocecal valves are actually incompetent. They don't, they're not continent, and so you are going to experience leakage if you don't do some sort of wrap. And so Dr. Sheldon's technique was almost like what he transferred his knowledge from being a pediatric surgeon to pediatric urology, and just the Nissen fundoplication type wrap he would do around the fecal stump, and that has served us well. So our fecal incontinence rate when we do the Malones is pretty low.
Pramod, on ours, we're still doing application. We're still doing a little bit around it. It's not just, and I have done laparoscopic cases where I have not done anything except pull it up and it works. But I think if you're doing open surgery, it's foolish not to add that additional step. You're burning over it by wrapping it.
And we've done a couple of robotic.
Antonio's done the study, actually. It takes 3 stitches.
Yes.
In this continent. Am I right, Antonio?
You're right.
But I think, Mark, your technique of the wrap, and I didn't really think it was a fundoplication until you just mentioned that, Pramod, but that in essence it's more of an external compression than this typical imbrication. But this Intex patient was 35 years old and obese, so that's why, Daniel, I didn't want to open the belly and do all these other things, and I just said, listen, this is going to work or it's going to stenose.
Well, we have been very lucky with new Malones, because for whatever reason, and I think that's something that we describe with apparently with this when we create this new bowel segments, we've noticed decreased rate of stomostenosis, and I think both Pramod and Mark mentioned looks like the Mitrofanov made of Monty about for whatever reason they have less stomostenosis, maybe just because the bowel is more I don't know. It's hard to say why, but our new Malones have a very much lower rate of stomostenosis than our one makes with the appendix. One of the things that we look for, even on the obese, there are a certain degree of adipose tissue that are, of course you can always put on the belly, if it's just in the belly button, but if the belly button is taken, there's a certain degree of adipose tissue that our colorectal surgeon will say, nope, you're going to get a syncostomy. Trying to do a stoma on you is not going to work, too much tissue to transverse. We have become very adept of measuring the appendix, and we have like a sort of a certain, almost like this appendix measure greater than 7 centimeters. Okay, we're going to split it. Less than 7 centimeters, we very rarely split it. And if it's less than 4 centimeters, we don't even use that. We know that less than 4 is not a good for a Mitrofanov. So we have sort of we have adapted that because we had a little bit more complications with the split appendix. And I think I really felt very interesting in Dr. Dean's technique because, like he said, I think keeping them together and not creating that separation of the mesentery might help with the vascularization and might give you better results. I mean, something that I might be willing to look to do it too. But again, we have, and the next step for us is actually trying to we're recording the abdominal wall thickness as well, because in our world, that's, it's not like we have all the Brazilian skinny people.
Greg, there's a question for you here in the YouTube. If someone is considering doing a Mitrofanov, but only using a shed tube for for cleaning, washing out, do you think there is space in the umbilical scar for using both, like the same principle you suggested?
Absolutely. And again, so I'm trying to understand the Chait tube is just in a standard location. It's not coming through the umbilicus. If you have if the umbilicus has not been operated on, it's perfect. I think the other key thing that I found is that if you look at the umbilicus, you want to go low, but do not go into the base of the umbilicus. The base has poor blood supply. You need to really make sure that you get that flap into the sidewall of the umbilicus, but there is always room. But I made the mistake, I think, of going into the very base, thinking that it's great because it's low, particularly with obesity, but there's poor blood supply. It's just skin lying over fascia.
Okay. Any other concerns? So we're going to go to the future. We're going to go back to the future.
Actually, a question, Antonio. So the question, if I understood that you just asked Greg, was, can they use the umbilicus for a Chait tube and a Mitrofanov?
Oh,
yes, at the same site. At the same site.
Yeah, that's what I wanted to make sure you understood. So I don't think that would be a good idea because your cecum is not going to be right underneath the umbilicus, and so that's probably not a good location for it. 1, 2, cosmetically.
Or something like a transverse. You can use it in the transverse area.
But putting a trapdoor in the umbilicus is probably
it's not very appealing.
No, I would say that for that patient, I would just convert the Chait tube and see if you can just give them an ACE. I mean, why not? They're going to be very much happier without the Chait tube.
All right.
Okay, Daniel, back to the future.
Sure. Let's see. There you go. So Antonio asked me to give this talk about how to establish a robotic program, and I really enjoy what Pramod said early. Is about if I've been here, it's because I'm standing on the shoulders of others, and part of a lot of what I've done in robotic surgery and crazy robotic reconstructions that I try to do wouldn't be happy if all the people on the panel wasn't doing them open and giving me the ideas of trying this robotic. I'm sure doing laparoscopic complex reconstructions is something that brings me a lot of anxiety prior to the cases, but eventually I think it's potential, the main reason why I see the robot as the future, or potentially a main laparoscopic tool to help laparoscopic surgeons complete this complex robotic surgeries. Like a lot, and I mentioned that because I think everything evolves, right? We started writing our essays, our papers in typewriters, and now, of course, we use computers that do a lot of the spell check and corrections for us. We used to present all this lectures. It would be very hard to do a Zoom lecture using one of those, but now we have this. And before laparoscopy came, we did open gallbladders, left a big scarring, and now we do everything with tiny little incisions. And now we have the robot. Could that be the next step? And I think that's exactly what it is. I don't think the robot is actually anything a different type of surgery. It's just a tool in laparoscopy. And the question was posed to me is, how do you establish a program? And I think in order to do that, you have to have somebody that is willing to see that the robot as this good tool that it is. And it's hard because the person has to be a laparoscopic surgeon, and we'll see some of the advantage that the robot offers is similar to laparoscopy. And so laparoscopic surgeons oftentimes going to say, well, why am I going to learn this new thing? Laparoscopy is hard enough. But once you get the surgeon champion that's going to push the program, then you have to get access to the robot. When I first started was in pediatric urology. I was in a hospital that was connected to an adult hospital. So that is actually a very straightforward way. If you partner with an adult hospital, you don't have to buy the new robot out of the blue. Most of the adult hospitals already have a robot, and it's pretty straightforward. You just have to kind of move your team into the adult hospital and do your surgeries. But ultimately, if you're working on a pediatric hospital that is a standalone, you might have to push your institution to acquire a robot, and that may create quite a bit of struggle. Eventually, if you do get a robot, you're going to need an operating room space that it's a little bit bigger than your usual operating room. You're going to have to get trained to use the robot. Even if you are very good at laparoscopy, there are some differences, and you're going to have to get your team trained as well. And once you're all ready to go, case selection is going to play a significant role. And we're going to go over each of these a little bit at a time. When I talk about the surgeon champion, usually it's going to be the urologist, but in the pediatric setting, it's of very much importance to involve all the services, especially if you're in a standalone hospital, because urology alone is not going to be able to drive enough volume to make the robot worthwhile for any pediatric standalone hospital. So you got to get your OB/GYNs involved. You got to get pediatric surgery. And if you see any adult hospital now, most of the services are involved. So as a urologist, if you want the robot, it's your best bet to get other services involved with you, and it will help you drive the hospital getting the robot. And as a surgeon champion, as I said, you have to be familiar with the advantage and disadvantage of the machine. And of course, cost is going to be the main disadvantage, and the cost is going to come not only from the initial cost of the machine, but also from the increase in surgical time and usage because of the adding steps that it includes, like the docking, and now you're going to want to be doing more complex procedures. And as a laparoscopic surgeon, you're going to understand that some of your benefits are going to be very similar to laparoscopy, and it's going to drive some people to say, well, why buy this machine? Why go through all this? We're doing fine with laparoscopy. But you have to push through the fact that the robot will improve your learning curve, not just for you, but for other people coming after you. And there's a significant improvement in ergonomics too, and the chance to what I think it is the most important, the ability to do all this more complex reconstructive cases, the stuff that we talked earlier here today, that are very, very difficult to do just straight laparoscopy. Why do you think the learning curve and all this is better? Like when you compare laparoscopic with the fixed instruments, with the robot, with the wrist, not only that, the 3D visual that you get, the depth perception, the magnification that the robot camera allows, the wrist instruments, as you can see here, versus the pretty much straight in and out movements and sideways that the laparoscopic instruments provide, and the fact that there is more of a direct correlation. So whatever you do in the console of the robot, the instruments are mimicked inside the patient versus the inverted movement of the laparoscope. And this has helped a lot of surgeons transition from open surgery straight to robotic surgery without having to learn laparoscopy, because they're almost doing the same type of procedure. So I've seen a lot of open surgeons adopt laparoscopic techniques since the robot have arrived. And I often tell them, trying to do laparoscopy versus robotic surgery for an open surgery is like trying to do open surgery with your wrist cast and with just one eye. So why wouldn't you adopt a machine that can give you two eyes and a free range of motion? But, oftentimes people just are sometimes stuck to what they're doing. And this is a fantastic graph to me that shows how a robot really changed the landscaping of laparoscopic surgery in pediatrics. So this study looked at the way pyeloplasty was done in the US over the years, starting in 2003. And mind you that in 2003, laparoscopic pyeloplasty was available for over 10 years. It was first described in 1993. And yet in the pediatric world, it only accomplished for 10% or less than 10% of all those pyeloplastic cases being done in 2003. But then in 2004, here comes the robot. And now by 2015, the robot accounts for almost 40% of pyeloplasties done in all ages, and almost the vast majority, over 90% of the laparoscopic pyeloplasties done in teenagers. So this didn't happen before the robot. It could have happened for the first 10 years, but certainly the whole robot opened the window for a vast majority of surgeons to learn the technique and really push it. So there is truly here a benefit on the learning curve. And on our own data here nationwide, when we looked at learning curves or in looking at comparing robotic versus laparoscopic, we found that adverse events and overall outcomes for the patient was very similar on a series of over 100 pyeloplasties of each of robotic versus laparoscopic. Our mean hospital stay was the same. Our operative time, our laparoscopic surgeon was very fast. And this point that I'm trying to make here is that this was one laparoscopic surgeon with greater than 10 years experience by the time we start counting cases, in comparing to 5 robotic surgeons, most of them fresh out of fellowship. But yet, because of the robot, what the robot was able to do is afford those surgeons to achieve a level of mastery comparable to the surgeon with more than 10 years experience, much younger, much earlier in their career. Again, showing some of the benefits that a robot can afford surgeons trying to learn laparoscopy. I won't say about surgery ergonomics, especially if you're trying to do some more complex cases like bladder neck reconstruction, appendivasectomies. Those cases, laparoscopy can take a long time. And if you're working in laparoscopy, you know how the strain it puts on your shoulder versus if you're working sitting down. So it could happen that after a long laparoscopic bladder neck reconstruction, your wife may be introducing you like this. This is my laparoscopic surgeon. Your arms can be stuck like that after 10-hour surgery laparoscopic. So there is a great advantage to the ergonomics of the robot. But ultimately, people are going to say, how can you get access? It's high, it's expensive. Well, how can you get the robot? Well, partnering with an adult hospital, like I mentioned, may be your best bet. Nowadays, the companies have offered a lease option versus a purchase option that might sort of take away the significant initial cost that is involved. Luckily, there are other platforms becoming available, so potentially this will drive the robot cost down as well. A lot of hospitals have acquired robots through donations. You know, pediatric hospitals are very good at getting donations from the community. So using one of those donations to get a robot is important. And talking to your administration, explaining that by getting a robot, that will be most likely an increase in overall volume for your hospital on areas that you may not be expecting to because of this halo effect that the robot creates. And people will continue to say, and I agree, robotic surgery is expensive, but when laparoscopic first came to be, and this is a nice paper in 1992, to compare 280 lap choles with 304 open, and they found that at that time, laparoscopic surgery was more expensive because it took longer, it had a higher operating cost because of the instruments at the time, and that was all true despite the shorter hospital stay. So again, just to remind some of the laparoscopic surgeons that saying like, oh, robotic is too expensive. Yes, it's too expensive now. But 10 years from now, when there's more competitiveness on the market and other things, it might come down to a price that's more reasonable. And it might make certainly totally sense to be doing this case. You will need an operating room space. Why? Because the robot takes a lot of space. You're going to need workflow. And you don't want to be moving a very expensive piece of equipment left and right into the hospital that will lead to potential damage in the robot. So this is what a room looks like. It's pretty open. You can see there is a boom. There is another boom for the robot. There is a robot down here. You're going to have space for one or at least 2 consoles for you to work with your trainees. And anesthesia is going to have their space too. So having an ample operating room is important, and planning this ahead of time is going to be important. The surgeon's going to need to be trained. And you're starting your training in a simulator nowadays. There are multiple simulators. You want to see some cases. You want to participate in animal surgical labs, which will give you the first sort of a real life feeling of the robot. And eventually you're going to have travel somewhere where you can get the certificate. For right now, it's only Da Vinci is offering the certificate. You're going to come back home and start your experience with some proctor cases, probably 5 to 10, which you're going to bring somebody or use perhaps an adult colleague. And it's going to be very important to establish a mentorship with either your proctor or somebody that you know that you can change ideas, somebody from another institution that has some experience. Oftentimes people have this mini fellowships. We do offer one here at Nationwide Children's. We have had a couple physicians from actually Brazil come, spend a week or 2 with us, watch cases, work on the simulator, and even participate. And we offer them a full day animal course here. And eventually prior to leaving the US, they stop by in Atlanta or one of the other Da Vinci facilities, do their 1-day training, get their certificate. It's a very nice way to accomplish that. And I know there is also one in Chicago with Dr. Gundetti. He does that, the same idea. You have to establish your team. This is very important. I know we're surgeons. It's all about the surgeons. But while you're sitting on the console looking good, doing your surgery, you're going to have very little access to the patients. So physiology is going to be very important. Most of the time, the patient is completely covered with your machine. This is a patient undergoing a bladder neck procedure. And you can see the head of the patient is completely covered. The anesthesiologist has very little access. So the preparation for the case by you, by anesthesiologist before the robot stock is very important, and having a team that you can trust is going to be very important. Your circulator is going to bring that robot in, and it has to be somebody that knows what they're doing. And finally, your assistant, your bedside assistant. It's probably good if you're starting to have one of your partners as a laparoscopy to help you, or a resident that is somebody that has had experience with the robot, because they're going to be passing instruments in and out almost in a blind way a lot of times, passing needles, taking needles out. Here's an example of somebody passing a needle to a pyeloplasty. And in the worst case that can happen is if you lose a needle or you create an injury by passing an instrument that you might not see because it's off your screen. So have somebody that you can trust, or eventually build somebody in your team. The assistant is probably one of the most important, because again, you are sitting on that chair by yourself and a lot of things are still happening around the patient. Now, of course, case selection. You want to start with something that you're comfortable with, especially open, or if you're a laparoscopic surgeon, something that you're comfortable doing laparoscopic. Nephrectomies, semi-nephrectomies, and pyeloplasties are the best case to start. Then you can evolve to more complex cases, ureter reimplantations, ureterochelicostomies, redo pyeloplasties, ureterostomies. And finally, as you feel more comfortable with your skills, you're going to try to do all the cases we talked about here early. And, mitrophanos, bladder neck reconstructions, bladder augmentations, and potentially combining all those cases into one case. But those are going to take a long time, but could potentially be where I see the most important advantage of doing things robotic, allowing for you to do this more complex reconstruction and potentially impacting the recovery of some of these patients. There are going to be many obstacles of doing surgery in children. Patient size, smaller trocars are going to be close together. There's going to be less distance. The greatest chance for collision. The abdominal wall is thin, so the trocars can slide out. And another very important point to have a good bedside assist, because when the trocars slide out, you lose your pneumoperitoneum. A lot of the other trocars may slide out, and you're on the console and not scrubbed in. You have to have somebody by the bedside who can quickly put those trocars back in and regain access to the abdominal wall. And a lot of surgeons, especially laparoscopic surgeons, get thrown off by the idea, especially of the newer machines, that they only have 8mm trocars. They don't have smaller instruments. So if you're doing laparoscopic for 3-5mm instruments, going to 8mm may seem a very large size, but on the great scheme of things, probably not. At least the way I see it, most plastic surgeons have noticed that incisions less than 1 millimeter or less than 1 centimeter tends to contract instead of to expand as patients grow. So I think now that all the trocars are 8mm, this is actually a very good thing for the robot. To me, still the major obstacle is going to be your number of cases. And this is the number of cases that we have here at our hospital over the years. You can see we've been fairly stable for the last 5 years, urology, and we have a very good, strong pediatric surgery robotic team. But we do about 110 to 130 cases a year, and that's a year. And then when you compare to in a busy busy adult hospital like our sister Ohio State University, they do 235 on average surgeries a month. So that might be one of the major hurdles for us, because there's not that many cases. It's hard to get, with that number of cases, it's going to be hard to get faster and good and to train a team. It's also going to be hard for the hospitals to see value on buying a robot, because ultimately there is no mission. No money, no mission. So if you can't generate money with the robot because you don't do cases, there's going to be very little they can do. So that is for me the most difficult thing to get by. But ultimately, you're going to get to this point where you want to do the complex reconstructions that we did here. This is just an example that I want to put before we finish. Some patient, 6-year-old, that had a myelomeningocele with neurogenic bladder. He was incontinent and had about 300 cc's of capacity, and also with constipation. Key things for when you're doing this operation is to position this patient very well. If you're going to do a prolonged procedure, you want to pad them. You want to make sure they're nice secured to the table. You got to remember that docking with the old robots, once the parts are positioned and the robot is docked on this position looking for the pelvis, you won't be able to look at his appendix. So oftentimes we do a similar approach to look laparoscopic first and see if the appendix is of good length and mobilize the colon in order to prevent having to deal with that while the robot is docked. And ultimately, the procedure itself is pretty straightforward. I do a mitral bladder neck, where we remove a top part of the urethra up to the ureteral orifice. We place ureteral stents so we know exactly where the ureteral orifice are. We get around the bladder neck too, because not only do a bladder neck reconstruction, but we do a sling with cadaveric autologous fascia. And you can see the two ureteral stents. And then we repair that in 2 layers. And after the bladder neck reconstruction repair, we'll wrap the sling around 360 and secure it to the pubic bone. Following that, we tack the bladder up and we create our extravesical tunnel to implant the appendix, similar to the show here, and we implant the appendix. And in this patient, we did a similar fashion with, we used 7 centimeters of the appendix for the Mitrofanoff and used the remaining 2 for the Malone. And we do create a valve on the Malone with 3 stitches. It's a long procedure, this particular patient stayed a little bit longer than we normally use, but he did very well. And then it's dry with CIT every 3 hours and doing his Malone flushing. And here's his post-op picture after we took the catheter with the Malone catheter still in place. So in summary, yes, robotic is an expensive laparoscopic tube for now, but I'm pretty sure the cost will continue to improve. The number of cases will still be your big obstacle. But I think as more and more complex cases are being done, the number should increase. And while I presented a few ways for you to create or to start a robotic program, a pediatric robotic program, I'm pretty sure there are many other ways, and just take what you like from here and do the best you can. I hope to inspire, and as I do more complex cases, all I want is more and more people to embark on this journey of doing things robotic. It's pretty cool. And I do think, I don't know if it's going to be the future, but right now it's looked as the future. I mean, who knows what's going to bring next, if there's going to be even a better robot or a better way to do this. And if you have any questions or you have anything, any interest in coming by, I mean, our doors are always open. Of course, once this whole thing, COVID, goes by, we will be glad to have anybody over here in our hospital. Thank you very much.
Thank you, Daniel. It's a pleasure to hear your talk. Yeah. I think it's very important to have guys which are devoted to laparoscopy and to robotic mainly, because I think that the way is to have really some masters spread out, and we have to have a good name beside us. That's how I'm doing Brazil. I have a former resident who is an adult urology, but the guy is a genius in robotics. In all the times that I need, I bring him together, we share, and I think it's a way. I think when you are starting, it's nice, but for us, it's better to have a good friend beside us. What do you think, guys?
I agree.
I agree completely. I'm at an adult hospital, and we're building a freestanding children's hospital. And so the question came up about the robot, of course. And certainly the other group, Daniel's transplant here, they're probably the biggest users for donor nephrectomy and then actually doing the transplant with the robot. So that's another group that you could leverage. But we're bumping up against a real problem, because right now the SI has better articulation than the XI with respects to the instrumentation, but it's becoming obsolete. And because there's not enough pediatric providers that like the SI. In the city of Richmond, there's 8 SI robots that aren't even being used by the adults because they want the XI model. They sit in the corner. So my plan was to leverage that. But if they're not going to make the parts, then we're going to be forced to use the XI and the 8mm ports. And so, but again, our volume's fairly small. I did 31 cases last year, and that's pretty low. If you look at the big picture, and the adults are they have 3 robots and they use them every day. So I think as you articulated, starting with the straightforward stuff, I still use laparoscopy for orchiopexy. I tie the vessels, and that's just to keep that technique up, because in the back of my mind, I'm not sure where this whole robotic thing is going. So I think you do have to keep that skill set up. The one thing I did want to mention, and you kind of touched on it, is teaching. Without question, with 2 consoles, allowing a fellow or resident to participate is much easier than when you're doing laparoscopy, because they're not doing much if you're doing a laparoscopic pyeloplasty. But if you're doing a laparoscopic with the robot, you have the console, you can have certain steps they do on this one, then the next steps on the next patient, with the pyeloplasty. So I think for teaching, without question, the robot is hands down the best. So.
Yeah.
Daniel, I think you under-leverage the value of robotic surgery for reconstructive surgery as well for urology. And that is the bladder neck is, in the patients we operate, the most difficult thing to see.
Absolutely.
The pelvis, yep.
Robot, you overcome that dramatically. And I think your ability to do a bladder neck reconstruction under good visibility is superior to an open operation. And the other thing I think where you have a huge advantage is you're doing this surgery in situ. We do a big abdominal incision or even a small one. You're pulling things out, right? And they're not in situ. So where I've seen the huge advantage is pyeloplasty.
Yeah.
Big renal pelvis, things like that, where you're doing it in situ, you can see the fundal anastomosis. I think that can also be transferred to Mitrophanoffs because you can see it. The problem I have with the lap robot Mitrophanoff is they never secured the channel very well or saw where it was going to go. You can overcome that a bit with the robotic approach. So I think don't under leverage yourself, because I think there's some tremendous advantages that you have over even the best master open surgeon.
Well, but only here because of you guys.
Yeah, and the other thing I wanted to bring up is the bladder neck operation you did is actually the one I do open. Mitchell bladder neck test. So I don't do a sling or a bladder neck reconstruction in isolation anymore, because your sling has to be occlusive, and the bladder neck seem like they're pretty wide. So narrowing it and then putting that sling on, and gosh, this goes back to Dixon Walker, Bernie Churchill, Vipul Upudahe in New Zealand described this, where you just leave it attached on one side and wrap it and bring it up, but you're narrowing the bladder neck. That's actually the one I've gone to because it's worked. 80% is hard to get over. It gets up into that 90-95% success rate, which I've struggled with forever. But nice technique, nice approach.
I think that we do the same thing. We always couple our bladder necks with a sling, and we're getting that 90-92% success rate. Yeah. We do the young D's though, not the Mitchell.
Yeah. We do. Okay.
I just find for the robot, the Mitchell is very it's a little bit easier.
It is easier. You cut out the triangle and
yeah, and it helps me eventually. What I'm doing nowadays, which I recommend if you're going to do robotic, is you start with the bladder neck, and then you try to get with the reconstruction, then try to get behind it, because then you know exactly the depth. Sometimes that's the difficult, because before we used to try to do the dissection behind the bladder, in that plane between the bladder and the vagina, or the bladder and the rectum, and that's a very hard plane to sometimes get all the way down there. Nowadays, come from above, open the bladder neck, and then now I know exactly the depth that I have to go to get around it, and it makes my life much easier. Before it was it's quite a difficult, and that's probably the hardest part of the procedure to get around. But now with the bladder neck already open, it's really easy to know exactly the depth you need to go.
Henri Lotman made that look so easy in his first video, didn't he?
One of the approaches is I was talking to CK about this, is doing the reconstruction, then waiting, and then if you need a bladder neck, come back robotically. You see, and then of course you've done the hard part, but he sometimes is on the cutting edge, but he'll go. That's his approach right now. So yeah, it's interesting.
I mean, that's more and more. What happens right now to me is that I have not been able to get patients like the easy ones. That just don't come by. I mean, if you're going to be selective, you're never going to do this case. Like the other day, I did a kid that had a bladder augmentation, 2 redo PSARP. No, sorry, had a bladder neck procedure and a Mitrophanoff and 2 redo PSARPs. and they landed on my lap for me to do an augmentation robotic. So I thought, sure, we'll try. So you don't have, eventually, if you're gonna try to do those patients, luckily they are young and they heal well. I mean, the key thing that I would tell you is it's not previous operations. The worst thing that they can have to make your life harder is have a shunt. Shunts are terrible things.
I did a case recently with my partner of a utricle cyst, which was extremely nice. He dissected up to the very low. We'll never go there so easy.
You can do that
with robots. It was really nice.
And I know Mark's going to speak to this. He's shaking his head. The other is a very high UG sinus. You can get access there very easily and see, and then combine that because you're already in this position, the lithotomy position. So the robot above, mobilize, isolate, and then when you're pulling things through, you're already in that position to secure them. So, and one of the other cases I've done is, I should have shared this, a nice video of a sigmoid vaginoplasty, and robotically, it's same principle. You're in lithotomy, and you can take your segment of colon, flip it, and then with the air seal which allows you to have pneumoperitoneum with a big opening. The abdomen's insufflated. You can put your fingers through, pull it down, and it's markedly less morbid than an open procedure for that.
Yeah, I've been trying to get my colorectal surgeons because some of the times they do when the rectum is high for the coag, they do some of the dissection laparoscopically, and I see them struggling doing the laparoscopy. I said, why don't you do this with the robot?
So Daniel, you had 63 cases by Pete surgery. Here we do about 3. What are they doing? Robotic?
One of the main pediatric surgeons here does a lot of morbid obese surgery robotically. He converted all his laparoscopic to robotic, and he loves it because of says no strain on his shoulders anymore to try to do those.
You broke up.
Sorry, it's for he does surgery. One of the main person does surgery for morbidly obese, like gastric bypass, and so that's a large number of that. Our surgeons like to do single. The other thing they got into was single port cholecystectomy. Mm-hmm. So it's small things, but once they start getting into it, and especially some of the surgeons that were they did some laparoscopic, but they really didn't do a whole lot of laparoscopic, and then all of a sudden they get this machine, and then their ability to do things kind of rises to a certain level, not to the level of an expert laparoscopy because they can't get there like in laparoscopy, but with the robot kind of helps raise their level to the point they feel confident on doing this more complex procedure. So then their number starts going up. But the fact is that they have to get into console first to see that, and that's oftentimes the hurdle. And we have been very good at having them sit down and go do it. And we created what's called a maintenance of certification. So every 3 quarters, we evaluate everybody's cases, how many cases you've done, and if you haven't done enough cases, you have to go through like a little training on the robot and do certain amounts of things on the simulator just to keep your skills.
Daniel,
that's a great recommendation. We have a moderately busy bariatric program that they do laparoscopically, so maybe I'll use that suggestion.
Yeah. And if you want, I can add them in touch because Mark Mikowski, which is our bariatric surgeon, I mean, he switched and he loves it. He totally loves it.
I might reach out.
No problem.
Daniel,
great, my friends.
The importance of safety and the maintenance of credentials.
Yep.
Yes.
The other thing that we do here, and I'm trying to get our colleagues to do it more frequently, is that once a quarter, we have everyone that does robotic surgery, including our nursing team, our bedside assistants, because that's key, right? It's a team approach here, and getting that team to play well is important. So we actually will simulate a catastrophic failure.
I was going to ask that.
Because nobody knows how to undock in an emergency. They don't know where the key is. And so we simulate that because you want to know how to do that when it's not an emergency. So everyone's trained on doing that. So I think.
Pramod, do you have a video of that or a manual or anything that you could share, or is it on the fly?
It's on the fly, but Mickey Doherty, our newest addition to our faculty, I've kind of tasked him of formalizing that. It's been kind of ad hoc that I've been pushing
Yeah,
that.
yeah. Mhm.
I mean, we can't have a surgical meeting like this without talking about safety, right?
Patricio talks about that too. I think it's
very important.
It is important because you never know when's going to happen. You're gonna, like Pramod says, the more you operate, the more at risk you are. Eventually you want the bad lottery of hurting a patient and hurting a big vessel, and if the team is not ready, then you won't be able to turn that patient. Everybody has to have their goal they're going to do, open assist, and anesthesiologist has to be ready. And that's the whole importance of having a team and practicing those things. It's important.
So Daniel, the other advantage of the robot is the simulation. I mean, let's be honest, our future, there's more of us and there's less disease to operate on. And so if you can simulate surgical technique, like with the robot, it actually helps with the training and actually keeping your skill set up. So I think those things are all critical for the robot, is utilizing the extenders for surgical technique, right? The simulation ability of the robot is far greater than open surgery.
Yes.
I think we need to remind our hospitals of that we've got to have champions like you started with. I think it's really important.
Yeah, and ultimately, like you said, simulation is going to overtake a lot of what we do, especially when you have technology like this. I mean, right now we do the simulation, but we also have, like I said, every 6 months I try to plan animal labs where I can take not just if somebody's here, I'll take them, but mostly it's for the fellows as well, so the fellows can practice, because I tell them, I do want to let you do some of my complex procedures, but truthfully is that I am still learning some of them. I'm still kind of struggling to the fact of getting faster. So every 6 months I take them and say, now here's a little pig, we'll go forward, do everything you saw me do it, and I was just going to watch you do it, and you're going to have a chance. I have said that the pig is much easier to do, but at least it's something.
Well, my friends,
Antonio,
as far as we come to the end of this extraordinary discussions of experts, Pankaj, I'm feeling bad because I would invite you for a table with a lot of drinks. If we are personally here, some wine, some caipirinha, some barbecues, some fish for Greg. The first time I invited Greg, I did a barbecue for him, and I noticed that he was a vegetarian, and he was saying, "Excellent
salad
dressing
dressing
that you have for the salad."
It was wonderful. We'll have it next year.
Yeah. So I want to thank you all for this very informal discussion. It has been recorded. It will make it more promoted in the YouTube, so more people will have access to this. This is a topic, a tough topic. So it's very selected, the people who are really more concerned and who do it actually. But anyway, it was a high level, and I want to thank you all. And I hope that as far as we finish with this pandemic, we can come together and celebrate life and our taste for medicine and children. Okay?
great.
Thank you.
Thank you. Thank you, Pankaj.
Thank you, sir.
Thank you all. It was great,
Obrigado.
exceptional.
Obrigado.
Obrigado, de nada. Bye-bye. Have a good weekend, guys.
You
Have a
too.
good weekend.
Good
Bye-bye.
weekend.
Hi,
Good weekend. Bye-bye.
everyone.
Bye-bye.
Great seeing you all.
See you later, guys. Nice to see
Bye-bye.
you.
Bye-bye.
See you soon, I hope.
Okay. See you soon. Bye-bye.
Yes, absolutely. Everyone stay healthy.
Yes.
Yes.